in terms of discovery of pathways that involved in the development of pulmonary hypertension, pulmonary arterial hypertension, and obviously consequently later maybe discovering medications for that. So we dedicated 2 sessions in the morning for the TGF-beta superfamily pathway. The work has been done in it, and some more exploration of this pathway. And obviously later on, I will be hearing more about the STELLAR study with sotatercept involvement in the treatment of PAH, and then some long-term data as well. And then the second morning session will be about the GDF pathway and the work, and then of course the medication that have been developed as well. It gives me great pleasure to introduce the first speaker who came all the way from Harvard to give us about his work in the pathogenesis of pulmonary hypertension, and specifically in terms of involvement of the TGF-beta superfamily. Professor Paul Yu, he is the director of the Cardiovascular Research Center at Mass General Hospital. He's also associate professor and cardiologist who's running a cardiology clinic, Cardioroma clinic, and Mass General Hospital and Harvard Medical School. He will be talking specifically about TGF-beta superfamily pathogenesis, involvement in pathogenesis of PAH. So it really gives me a great pleasure. And it turned out, by the way, when I was reading his biography this morning, that we overlapped at Duke for 2 years or so, but of course we had never had a chance to meet. So Paul, the podium is yours, and people are waiting to hear from you. Thank you.
Good morning. Thanks so much for that kind introduction, and thank you to the hosts for inviting me to speak today. I wanted to give you an overview of some of the work that have led to these recent developments that were just alluded to that have resulted from some basic investigation in this pathway. These are my conflicts, and as everybody in this room knows, there is a wide variety of etiologies that can lead to pulmonary hypertension, and we think that the pathogenesis of these diverse conditions is probably shared, but our focus in our research has been based on understanding the etiology of heritable pulmonary hypertension as a subset of idiopathic pulmonary hypertension and as a subset of group 1 PH, thinking that these monogenic conditions might yield more insights into the pathogenetic mechanisms. So, as of now, we have still relied on 3 main pathways that we've targeted for clinical pulmonary hypertension. Obviously, the endothelin pathways, the nitric oxide pathway, and the prostacyclin pathway. And looking back, this is almost 30 years ago now, but the work that led to the development of epoprostenol is even older than that. But we've come a long way in terms of developing new tools in our pharmacopoeia for treating pulmonary hypertension, and with really, huge strides in the care of these patients. But a pivotal moment in our approach to this field for me was when we were training at Duke, and shortly afterwards, in the year 2000, there was a discovery of mutations, loss of function mutations in the BMP signaling pathway, and the majority of patients with familial pulmonary hypertension were found to have loss of function mutations in BMPR2. And we know that these mutations affect all the different domains of BMPR2, the ligand binding domain, the kinase enzymatic domains, but also these mysterious domains that exist in the extra 500 amino acids after the kinase domain, that probably serve as important adapter functions for many other signaling pathways in our vascular cells. And there are nearly equal numbers of mutations in this adapter domain of this protein, which is unique in this pathway. As you'll see, BMPR2 is only one of 5 type 2 receptors that work in a coordinated fashion combinatorially with 7 type 1 receptors. And there are theoretical in vitro-based observations of interactions with all 7, depending on the biological context, but the most important interactions are probably limited to these 4 receptors, ALK1, 2, 3, and 6. And in the vasculature, we might say that the most important interaction is with ALK1. But we thought that this would be an immediate clue as to a way to target this disease therapeutically. But as you can see, with 35 different combinations of receptors and 33 different ligands, and a wide variety of tissues that express these receptors at different abundance, it wasn't immediately obvious which way we would go, and it wasn't very clear how loss-of-function mutations in just this one of 12 receptors would change the function of our vascular cells. And broadly speaking, BMP signals on the right side of this pathway activate the SMADs 1, 5, and 9 to promote osteoblast differentiation. That's how they were discovered. But they also have very pleiotropic effects on almost every other pluripotent cell in the body, and as well as on terminally differentiated cells. The other side, which many of you are familiar with, is the TGF-beta, and also active inside of the pathway, which all activate SMADs 2 and 3, and broadly speaking, these promote muscle differentiation and fibroblast differentiation. So these are the 33 ligands that interact combinatorially with those 35 receptor combinations, and if you look at BMPR2, it interacts with more than half the pathway. So it was really challenging when we entered this field almost 2 decades ago to understand where to begin and where the key players are in the vascular cell biology of pulmonary hypertension. But fortunately, we had some clues, which I'll tell you about. So one of the obstacles to understand this pathway is the nomenclature. Each of these ligands has a different name that derives from the biological context in which they were discovered. Obviously, the transforming growth factor ligands were discovered in cancer biology. The activins were discovered in reproductive endocrinology. Some of the GDFs were discovered in muscle biology. And the BMPs were discovered by a group of orthopedic surgeon researchers led by Hari Reddy and Kuber Sampath almost 30 years ago. And so, rather than think of them as these different names, it's probably easier to think of them all as growth and differentiation factors, because that's what they all do. They affect growth, proliferation of cells, they affect the cell fate, and they're important in developmental patterning, and a lot of different processes from the beginning of gastrulation. But I think that one very helpful way of thinking about what BMPs do in the biology of this disease is that they're powerful modulators of branching morphogenesis. And we know this in that these structures, these branch structures, ductal structures, vascular structures in every organ bed depend critically on gradients that form embryonically from BMPs, as well as several other growth factor cytokine axes. And this has even been modeled computationally using basic, very small finite number of elements, and you can replicate these beautiful patterns of branching morphogenesis just with the reaction diffusion equations that are predicted by the diffusion of these ligands down a concentration gradient. So we've come a long way from understanding bone morphogenetic proteins as simply proteins when injected into animals form bone. They're actually body morphogen proteins, and I think for the purpose of pulmonary hypertension, you can think of them as branching morphogenesis proteins. We could have called them any other name. We could have called them GDFs. But I think this would be more helpful in thinking about what they do in our disease. Now, we were very naive when we entered this field. We thought that we would get very quick answers just from inducing gain and loss of this protein in a variety of vascular cells. We did these studies in smooth muscle cells, in endothelial cells, and in animal models. And we could have thought that this would have yielded a drug much sooner, because it's known from this review from the Broad Institute that once you understand the genetic basis of a disease, your chances of success for developing a drug targeting that pathway go up 20-fold versus a pathway that is not consistent with any Mendelian disease. But there is a caveat to this, which is that gain-of-function mutations are easier to target, obviously, with inhibitors than loss of function is in this disease, and it's also much easier when the mechanism of disease is more obvious, and it was not that obvious in this condition. So this is one of the advances that helped us. 20 years of really beautiful human genetics work has revealed that BMPR2 is just one of 12 or 13 genetic lesions that can lead to pulmonary hypertension now, but BMPR2 is the most prevalent. But in addition to BMPR2, we have these other receptors and effectors, some of which I've already told you about, that are downstream of the receptor, and they're all highlighted in yellow, and you'll see that all these genetic lesions occur on one side of this pathway, and that's the BMP signaling side of this pathway. There have been no mutations discovered on the left side of this pathway as of yet. There are other mutations that affect ion channels, water transport channels, and other developmental patterning genes. And while not all of them depend on BMP TGF-beta signaling, some of them are very closely partnered and even co-localized in the cell membrane with BMP signal transduction protein, suggesting a link. So it's been, I think, helpful in understanding that even if we don't know the precise contribution of BMPR2 in every cell type, these other mutations really suggest that there could be an imbalance between these two sides of the pathway, just very broadly speaking. So this is still just a subset of group 1 disease, but it extends beyond idiopathic or heritable. We're seeing these mutations now in portal pulmonary hypertension, in HIV-associated pulmonary hypertension, and congenital heart disease-associated pulmonary hypertension. So even the manner in which these patients present to us doesn't always rule out a genetic cause. So what is the evidence that it's loss of this side of the pathway that contributes to disease? Well, it's not so straightforward, but I'm going to lead you through some historical developments in this field. We now know that BMP9 mutations are a major cause of heritable pulmonary hypertension, not as abundant as BMPR2 mutations, but in many international cohorts, it's quite clear that at least 1% of the group 1 population has loss of function mutations in BMP9 contributing. And this is confirmed on a biochemical level, as there's loss of ligand expression or ligand function with any of these loss of function mutations. And the idea that you might be able to correct this abnormality by simply giving back exogenous BMP9 was an idea that was promoted by Nick Morell and his colleagues at Cambridge several years ago, and they gave systemic dosing of recombinant human BMP9 protein to animals in 5 different models of pulmonary hypertension. And you could see here that the administration of BMP9 took a very severe degree of pulmonary hypertension after 8 weeks of development of the disease experimentally, and was able to partially reverse many of the signs in the animals, including right-sided heart pressures, right ventricular hypertrophy, but most impressively, a lot of the vessels that were seen to be closed in this disease model were then recovered in terms of loss of obliterated vessels. And our work has seemed to confirm this notion that loss of BMP9 could be contributing to disease. We found that BMP9 levels were not compromised in most cases of group 1 PH except for one, and that's portal pulmonary hypertension. And that's because BMP9 is made in the liver by stellate cells, hepatic stellate cells. So it's not surprising that with severe liver disease that might be compromised, but since this is in the pathway, it suggested that you could have an acquired defect in BMP9. And in fact, this predicts outcome in this population and in group 1 overall. But the function of BMP9 in our vascular cells is highly context dependent. And you'll see here in this work from Mark Ormiston that depending on the genotype of the cells, and we've replicated this depending on whether these microvascular ECs are recovered from healthy lungs or from lungs with pulmonary hypertension at the time of explant, that BMP9 can have pro-proliferative activities versus anti-proliferative activities. So to make things even more complicated, these ligands act differently, probably depending on the epigenetic state of your cells, or whether there's a loss of function mutation in BMPR2. And I think the most convincing demonstration of this pleiotropic effect is in this study done by our colleagues in Paris and in Grenoble, France, who showed that BMP9 knockout mice, instead of being more susceptible to pulmonary hypertension, are actually protected to some degree. And they could also replicate this by giving BMP9 and BMP10 ligand traps to the monocrotaline model or the Sugen hypoxia model. So what does this mean? You lose the function of BMP9 in forms of heritable pulmonary hypertension, but in experimental pulmonary hypertension, taking it away is somehow protective. Well, this is a controversy that persists, and we're still working on this. But let's take a step back. There's human genetics that support loss of function here. What about over here, and how can we use this as leverage for developing therapeutics? And that was a question we asked several years ago, following work from colleagues at Novartis and Nick Morrell, showing that if you use broad inhibitors of the entire side of this pathway, these small molecule kinase inhibitors, you could get very nice results in our experimental models of pulmonary hypertension. Unfortunately, these clinical efforts are limited by the toxicity of this broad suppression of half of this pathway. Some fibrosis is essential for maintenance of your connective tissues, and you will degenerate your heart valves at higher doses of these drugs in experimental models, shown in these studies here. But we wondered if we could replicate some of the benefit of this approach by just targeting some of the ligands. In this case, we used a protein, which is actually just a recombinant protein of the extracellular domain of the TGF-beta receptor. It's called TGF-BR2FC. And interestingly, it only targets 2 out of the 3 ligands in this pathway. So TGF-beta is in excess abundance in our group 1 pulmonary hypertension population, and higher levels of TGF-beta are associated with worsened outcomes. And we found that this TGF-beta ligand trap worked very nicely in vitro in blocking just beta-1 and beta-3 activity, and did not inhibit beta-2 activity, which is probably essential for valve homeostasis, so less likely to cause the toxicity that was seen in these broader inhibition strategies. And then we saw in monocrotaline and Sugen hypoxia models that the use of this ligand trap was beneficial in reducing pressures in hypertrophy and in the muscularization of the small vessels seen with monocrotaline. Much of it was improved. And this was actually comparable in magnitude to the effects that were seen by Nick Morrell and Novartis with the broad small molecule inhibitor strategies some time before these studies. So this is a strategy that has continued to be pursued. This is a compound that was developed by Acceleron, a startup in Boston, which then handed it off to Merck, and they have tried to explore it in scleroderma and interstitial fibrosis. That program is on hold right now, but we do have hope that this will be revived for pulmonary hypertension at some time. On hold because of difficulty in enrolling, I should say. So we have this. Now, if this strategy is almost as effective or indistinguishable from blocking this whole side of the pathway, this left us not sure about what the status of these ligands are, these other 15 ligands. This is just a limited sampling of them. And so we asked the question, well, what if we just block them? And I'll have to be honest with you, when we did the study, we were not expecting a positive result. We thought all of the activity was contained in just these 2 ligands, and that these would just be along for the ride, because they had not been found to be important in pulmonary hypertension previously. And we used this probe molecule that we now know as sotatercept, but it's simply one of the activin type 2 receptors expressed as an Fc fusion protein, and it was developed previously for the treatment of anemia. And its development was stopped not because it was a bad molecule, but simply because they found a mutant protein that was, for their purposes, more effective for anemia. So it was available for repositioning because it hadn't been taken to its final indication yet. And what was the evidence that this might be effective? Well, one thing is that if we probe for activin A in the blood, it is higher somewhat in group 1 PAH. These assays are not the greatest assays, but GDF8 and 11 are detected to a lesser or greater degree in plasma, and they're not changed in group 1 PH. And if you stain the lesions of experimental pH and of human pH, you can see that some of these ligands are expressed in plexiform and obstructive lesions, suggesting that it's there. It's also turning out that if you look at experimental models or microarrays of human lungs that were explanted, that activin A, which is encoded by the INHBA gene, are at high abundance in the group 1 PAH versus control lungs. So there's evidence that there's gain of function of activin A. And so when we did these studies, we were a little less surprised that we'd get a therapeutic effect. In fact, the pulmonary pressures seen in monocrotaline pulmonary hypertension were nearly normalized, where when we gave a control treatment, this is sildenafil, the effects were much more modest. And there were only anti-remodeling effects, reduction of the smooth muscle hypertrophy, seen with this actor 2A Fc or sotatercept molecule, which got us pretty excited. But what would this do in more severe models? And the most severe model that we can use was the same one that Nick Morell used, where you allow the animals to progress to disease, severe disease at 5, 6, or 7 weeks. When we went up to 5 weeks, we already had pressures that were almost systemic levels of pulmonary hypertension. And the effect is not as strong as in the milder prevention models, but you can see here that there is a substantial reduction in pressures and hypertrophy. And what's most exciting is that we see a lot of occluded vessels, 10% is nearly, in our disease model, and these are normalized to something closer to baseline. And the effects might be attributed to some reduction in proliferative cells in the vascular wall, but also there's a loss of apoptosis sensitivity, we think. There are less apoptotic cells in the intima that's then restored with the treatment. So these might be sensitizing the cells back to normal mechanisms of growth control. There is, in addition to these anti-proliferative and pro-apoptotic effects, evidence of effects on different lineages of vascular cells. I'll just show you this, which is an impact on pulmonary smooth muscle cells. We know that TGF-beta can induce a lot of myogenic genes and introduce a contractile phenotype in our smooth muscle cells, and that's shown here in red. The transcriptional signature of these ligands that are inhibited by sotatercept is a little bit different than TGF-beta. It affects a lot of the same gene products, including these smooth muscle cell identity proteins, these matrix metalloproteinases, and these extracellular matrix genes. But the balance in these different genes is quite different, suggesting that activin GDF ligands that are blocked by sotatercept, they are fibrotic ligands, but the fibrosis that they induce is something quite different than TGF-beta, probably not entirely redundant either. There's also some potent anti-inflammatory effects seen. The recruitment of CD11b monocytes is almost completely abrogated when these Sugen hypoxia rats are given sotatercept. And we're still trying to understand the mechanism of this, but it looks that activins are not only made by mononuclear cells and macrophages in our disease pathology, but also these same cells are very responsive to the effects of activin and GDF. Now you might wonder, so we have a ligand trap, actor 2B, that inhibits a large number of ligands, and I told you previously that other approaches that were so broad were not so well tolerated. There was an attempt to try and dissect this function by using antibodies that only interacted with a subset of the ligands of sotatercept. Here we used an antibody that blocked A and B, and then an antibody that blocked GDF11 and 8. And you can see that when you use these bispecific antibodies that don't block all of the ligands of sotatercept, you get a partial effect that's not statistically significant. Even when you use a cocktail of antibodies that bind all 4 of these ligands, you only get a partial recapitulation effect of sotatercept. And this has been replicated by other labs as well. There is something redundant about the 15 or 16 ligands that are inhibited by activin R2A, and the precise contribution of all those 15 or 16 ligands is still undefined. There are some really exciting suggestions experimentally that not only do we have effects on vascular wall remodeling, but there's direct effects on RV hypertrophy due to afterload, independent of the effects on the pulmonary vasculature, and that's shown in this set of experiments where the RV outflow tract, the PA is banded, leading to pressure overload, and even without acting on the pulmonary vasculature, the same molecule can inhibit RV hypertrophy, suggesting anti-myogenic effects there. So this is the main reason why Acceleron decided to take this into clinical trials. It's because when we compared side by side with standard of care therapies in these models, which we have to acknowledge are limited because they don't fully recapitulate the spectrum of human disease, they only develop in 3 to 5 weeks. So it's very hard to imagine that they fully recapitulate disease that takes years, if not decades, to develop in humans. But nonetheless, the efficacy was better in each of these models. And even in this delayed treatment context, where you allow the disease to progress to a severe degree, we only can make a difference in this experimentally by using combination therapies, ambition-style therapies, but the single treatment with the actor 2 Fc in this experimental model seemed to rival the combination therapy. And so people ask, well, why this and not any of the hundreds of other promising drugs that were previously developed, demonstrated by labs to have efficacy in these models? And they're basically these reasons. It's because I think this drug had a mechanism of action that was rooted in the human genetics. And that this drug was also shown to be quite safe in 400 subjects, and they understood its pharmacokinetics and its pharmacodynamics. And then when we did these experiments, there was very consistent evidence of efficacy, and the efficacy was much more dramatic than what we had seen with other agents and with even standard of care approved therapies. And I think this was very compelling. But ultimately, it took the courage. The company had to make a big bet. I think the outcome would impact whether the company would have any future, but also there were many people in this community and in this room here who were able to step up and help bring this concept into the clinic. And there were patients, of course, who were instrumental in advancing this. And so my colleagues are going to tell you much more detail about the clinical efforts that followed, but we are all familiar now with the PULSAR result, and the primary endpoint was reached. And we know that this was an anemia drug, and so a major limitation, but turns out not to be a high percentage of the patients, is that a number of our patients, maybe as many as 8 or 9%, are outside the eligibility based on having a baseline degree of polycythemia, which would go to unacceptably high levels on treatment. On the other hand, though, there's probably 20 or 30% of our patients that are anemic who would benefit from the increased oxygen carrying capacity of this drug. Now, some people are still under the impression that we're only impacting red cell levels as our mechanism of effect, but I think any of the people involved in the trials or who've looked at the data closely that can tell you that the hemodynamic effects are independent of any effects on red cell levels and often precede effects on red cell levels by months. There are other side effects that are associated that my colleague is going to tell you about. One interesting side effect that is becoming more and more evident as treatment continues beyond the original randomized controlled trials is that there are telangiectasias and bleeding observed. And this is a subject that could be for much longer discussion. But I will answer a question that we've had for a long time and that many of people have had, which is, are these animal models any good for predicting success? So we now have 3 successful phase 2 trials in the past decade that have used this endpoint of pulmonary vascular resistance, and in profiles of patients with, to some degree, similarly severe disease with Woods units that are anywhere from 8 to 10 to 15, and a reduction in PVR that's been pretty variable and may be related to the severity of the patients that were enrolled. Now, we have the benefit of, since these drugs were just developed in the past decade, of going back and looking at the animal model data, and this is what we see. And now, many caveats, because these are run in different labs, and you don't know if this is their best experiment or their worst or a very representative result, but generally, the preclinical efficacy in the monoclonal model does, to some degree, predict decrease in PVR in the clinic. We don't have as much data on Sugen hypoxia, but we can draw this line here, which maps almost onto the PVR efficacy in the clinic. So what we could tell you is that these models probably have some predictive value in the clinic, but you should have very high efficacy in treating a disease that only takes 3 to 5 weeks to develop. So I'll summarize by saying, while this is a useful paradigm of BMP TGF-beta signaling, BMP9 still has a function that's not completely resolved. TGF-beta is an idea that I think has been supported by the preclinical data and deserves some clinical validation. Sotatercept was a very opportunistic and fortunate development in that we had an existing agent that had these safety data, and it turns out a lot of really beneficial effects in very different tissues, including the endothelium, smooth muscle cells, myeloid lineages, and even the right ventricle. So we think that activin GDF signaling as a fibrotic pathway is a useful paradigm for PH. And then the general paradigm of dysregulation of this pathway remains intact, but some of the subtleties, given the complexities of the biology, still have to be resolved. And so This was a slide that Marc Humbert recently included in one of his reviews in this topic, and we're hopeful that this concept, that this pathway will have therapeutic yields for years to come in pulmonary hypertension will be proven over time. Thank you. Appreciate your attention, and we'll take questions at the end.
Thank you, Paul. It was very illustrating talk. And join me here, please. We will have questions and answer at the end of the session. So the next speaker will be Marius Hooper, who is joining us online. Marius will be going into deep look at this, the STELLAR study, so the role of sotatercept in treating pulmonary arterial hypertension. So Marius is being connected now to the to the screen, and I don't know if he hears me now.
PULSAR was the phase 2 study with sotatercept in patients with pulmonary arterial hypertension. It enrolled patients with PAH who had been pre-treated and randomized them into 3 arms, 1 placebo arm and then 2 sotatercept arms, different dosages of 0.3 and 0.7 milligram per kilogram, administered every 3 weeks. The primary endpoint of PULSAR was change in PVR from baseline at month 6. And the study was positive. You see that there was improvement in PVR with both dosages and about 2 Wood units with the 0.3 dose and about 3 Wood units with the 0.7 dosage. And there was also improvements in 6-minute walk distance in these patients. During PULSAR, almost no side effects became apparent except for the increase in hemoglobin, which was already mentioned. However, PULSAR had an open-label extension study. So all patients participating in PULSAR were able to switch to an open-label extension. They either maintained their dose once they had been assigned to sotatercept. Those that had been assigned to placebo then went on to active therapy. And what we saw here is that the improvements that we saw in PVR, 6-minute walk distance, NT-proBNP, they were also observed in more or less the same range in the patients formerly assigned to placebo. And those who were assigned to active medications, they maintained their treatment effect for the observation period that lasted between 18 and 24 months. But then we also at the same time saw the now typical side effect profile of sotatercept that you can see here. And once you just focus here on the right column, this is all sotatercept patients combined. You see that what we observe here is bleeding complications, mostly epistaxis and increases in hemoglobin, thrombocytopenia, and telangiectasia. This is the typical side effect profile that we have to deal with when we treat patients with sotatercept, and I will come back to this in a moment. However, this is what we knew when STELLAR was started. And STELLAR was the phase 3 trial of sotatercept for the treatment of pulmonary arterial hypertension. Design was similar to the PULSAR study. So STELLAR enrolled patients with group 1 pulmonary arterial hypertension and functional class 2 or 3 who had a baseline PVR of more than 400 dyne or 5 Wood units, 6-minute walk distance between 150 and 500 meters, and they were on stable background therapy. They were now randomized 1-to-1, so just 2 arms, either to a placebo or to sotatercept, which started at a dose of 0.3, was then up-titrated to the target dose of 0.7 after the second administration, and again every 3 weeks. The main double-blind treatment period was 24 weeks. And after that, most of the endpoints, including the primary endpoint, which was change in 6-minute walk distance, were assessed. But then the patients were kept on double-blind medications during extension, which lasted until the final patient had completed the 24-week study program, and at that time, time to clinical worsening was assessed. And the study also had right heart catheterization and echo at baseline at week 24 with center readings of the echo. Primary endpoint I just mentioned, typical phase 3 endpoint in our studies, so it's change in 6-minute walk distance, but then also a number of secondary endpoints which were tested hierarchically. The study enrolled patients that were very similar in terms of phenotypes and then patients in PULSAR and other PAH studies that we see for the time being. 323 patients were randomized. Their mean age was 48 years. Almost 80% of them were female. Most of the patients had been diagnosed with idiopathic or hereditary PAH when functional class 2 and 3 per inclusion criteria. Prevalent patients with an average time from the initial PAH diagnosis to enrollment of 9 years, and heavily pretreated, 61% on triple combination therapy, the rest mostly on double combination, and 40% of the patients were receiving treatment with the parenteral prostacyclin analog. So fairly stable, but ill patients, you see that the PVR at baseline was about 10 Watt units or so, and the PA pressure above 50 millimeters of mercury. The study met its primary endpoint, though there was a change in 6-minute walk distance from baseline at week 24 of about 40 meters. And this was entirely driven by the improvement in the sotatercept group, whereas the placebo group remained more or less stable. And this is something you will see with all the results. It was really driven by improvement, not by deterioration in placebo, which I think is one of the important findings and important to note in this study. In addition to that, the study made the first 8 out of 9 pre-specified endpoints, including multi-component improvement, which was a composite endpoint that included changes or maintenance of good functional class 6-minute walk distance and NT-proBNP. There was hemodynamic improvement, which I touch upon later. Same for NT-proBNP, quite remarkable here. There was also improvement in WHO functional class, time to clinical worsening, I will show you. The French low risk score improved as well. And there were also improvements in 2 out of 3 domains of the PAH SYMPACT tool, which is a PAH-specific quality of life questionnaire. And then finally, there was quite remarkable improvement in time to clinical worsening, which was defined in a typical way in our PAH trials. The hazard ratio was 0.16, something we've never seen before. This is an 84% risk reduction. And this was driven mainly by lesser need for increase of prostacyclin doses, but also by PAH-related hospitalizations and PAH deteriorations defined by a decline in 6-minute walk distance by more than 15% from baseline. When we look at the safety profile of the drug, we see that adverse events were common in both treatment arms. Treatment-related adverse events were more common with sotatercept than with placebo. However, treatment-related adverse events or any adverse events leading to treatment or study discontinuations or deaths or were rated as severe or serious were all less common with sotatercept than with placebo. That's kind of reassuring. And then the adverse event profile that we saw in STELLAR mimicked those what I've shown you from the PULSAR open label extension study. So again, bleeding events were quite common and more common certainly with sotatercept than with placebo. Mostly epistaxis, some gum bleeds, almost all of these bleeding mild and not needing any intervention. And then telangiectasia, here we have at the end of the safety period, the cutoff date, here we have 14%. Again, mimicking what we saw with the PULSAR study, and certainly much more common than with placebo. So it's certainly a drug-related side effect that we need to keep in mind. Increased hemoglobin as an adverse event was reported in 6% of the patients. The average increase in hemoglobin in the STELLAR study was 1.3 gram per deciliter from baseline at week 24. Thrombocytopenia has been reported. It's mostly mild in those patients and didn't result in study medication discontinuation. And there were also some adverse events reported about an increase in blood pressure that we should be aware of. So again, this is a safety profile, very few drug discontinuations or treatment discontinuations due to that, but nevertheless something that we need to bear in mind, especially the signal of the telangiectasia. Paul, you just mentioned that. It's reminding us that the drug is not specific for the pulmonary vascular bed. There are effects on systemic vessels, and we need to be vigilant about this, and I'm sure we will discuss this later. The results of the STELLAR study that I just presented were published about a year ago. And about 6 months ago at ERS, we presented and published at the same time with Rogerio Souza as the third author, an in-depth analysis of the hemodynamics and echo findings that we saw in these trials. So again, we had hemodynamics and echo at baseline at week 24 with central readings of echo. And this analysis to me is extremely fascinating. So let's have a deep look into what we saw here. First of all, systemic hemodynamics. There was in fact an increase in systolic and diastolic blood pressure. So about 4 millimeters of mercury. Of course, in most of these patients, many of whom tend to be hypertensive, that is not clinically relevant. But in some patients, it becomes clinically relevant, and some of these patients even need some antihypertensive treatment. And there's also, of course, the increase in the systemic vascular resistance, which is driving this increase here. The mechanism is not entirely clear. On the left ventricle, we see no meaningful and no significant changes in the end diastolic and end systolic volume indices. However, there's a slight 2% decline in left ventricular ejection fraction, which is statistically significant at a p-value of 0.02. We don't know what the clinical relevance is. My personal feeling is that this is not clinically relevant, but it's certainly something we need to watch closely. But to my knowledge, and Jona will comment on that, there's no sign at all on any clinically relevant LV dysfunction in the patients who are continuing in the open label SOTERIA study. And then the effects on pulmonary hemodynamics. They are remarkable and they are unique. There is a decline in the mean pulmonary artery pressure by about 13 millimeters of mercury. This is the most we have ever seen in the clinical trials with add-on treatments in pulmonary arterial hypertension patients. Interestingly, there was no change in cardiac output. It remained more or less stable on sotatercept. Even in patients started with low cardiac output, we saw very little increase in these patients, and not all of them returned to what we believe is a normal cardiac index of 2.5 or higher. So this is unique. So the improvement in PVR that we saw here, about 3 Wood units from baseline, substantial, but entirely driven by the drop in PA pressure and not by an increase in cardiac output. I'm sure we will discuss this during the panel discussions. Intriguing finding, and some people are concerned that there's no improvement in cardiac output. I personally believe that this contributes to the overall improvement in right ventricular function that we've seen in this study. We just reduced the workload of the right ventricle, which is shown here. First of all, we have a significant and substantial improvement in pulmonary arterial compliance. Again, this is highly relevant for the right ventricular work. Right ventricular work, when calculated as the product of cardiac output and mean PA pressure, also drops substantially. And there's an almost 3 millimeter mercury decline in right atrial pressure. Doesn't seem much. The patients started at 8, so most of them were normal. But this, once again, is a finding that is much larger than any other randomized placebo-controlled trial that we have observed before. And it's another indication of effective right ventricular unloading. Then also shown here in the echocardiographic findings, TAPSE did not change. So in line with the lack of a change in cardiac output, there's also no change in TAPSE. However, the TAPSE over SPAP ratio, which has become, I think, an accepted mark of the coupling between the right ventricle and the pulmonary arteries, improves substantially due to the decline in the systolic PA pressure. And there is a substantial reduction in the end diastolic and end systolic right ventricular area, about 20 to 25%. This is quite remarkable. And there's a slight 2% improvement in the right ventricular fractional area change. So the right ventricles, they do become smaller, and this results in a substantial and also statistically significant improvement in the degree of tricuspid regurgitation, Again, also something that has never been shown before with any other drug so far, but also I think many studies didn't look into this very carefully. So what we also saw as an indication of the improvement in right ventricular function, or let's say right ventricular strain, is the reduction in NT-proBNP. We take the least square mean approach is a reduction of about 1,000 picogram per milliliter. And the majority of patients, they come near the zone, which we believe is the green zone in patients with pulmonary arterial hypertension. We did correlation analysis with all the hemodynamic and echocardiographic parameters. So we looked at changes in hemodynamics and changes in echo findings and correlated them with changes in NT-proBNP. And guess what came out as the strongest correlation that we saw here? It was, in fact, the drop in the mean PA pressure, and that there was most strongly correlated with the improvement in NT-proBNP. In fact, the correlation coefficient was 0.55, which is very strong in the biological system. And also when we look at our primary endpoint, change in 6-minute walk distance, the strongest correlation was with the change in mean PA pressure. So this really signals that a substantial, meaningful reduction in mean pulmonary artery pressure, which we usually don't achieve with many of our other PAH medications, is extremely important for unloading the right ventricle and for all the clinical effects that we saw in the trial. And this is my summary. So it's not the typical summary where I list text, but I just want to highlight this. This is the graphical abstract from the ERJ paper that I just presented here. So we have a new compound called sotatercept, which is an activin signaling inhibitor. And we believe that it acts on the pulmonary vessels, and we have reasons to believe that it causes at least some degree of reverse remodeling of the pulmonary vessels, and thereby reducing substantially the mean pulmonary artery pressure, improving PA compliance, right ventricular work, the right atrial pressure, and NT-proBNP, all suggesting unloading, which we also see on echo with the improvement in the TAPSE over aspect ratio and the reduction in the size of the right heart dimensions. So this is an intriguing effect that can have substantial impact on the lives of our patients with pulmonary arterial hypertension. On the other hand, we have a unique new side effect profile, and we do not have true long-term data, no long-term data over 5 or 10 years or so. And again, we have to keep in mind that we are now using a drug that targets not only pulmonary vessels, but has effect on systemic vessels. And we may create a patient phenotype that resembles a bit that of patient with Osler's disease, so with HHT. And so over time, there may be systemic side effects that we need to be quite careful about. There has been a case report that will be discussed about gastrointestinal bleeding. And so we need to be vigilant. But at the end of the day, what we have here is a promising, exciting new drug. And I think we're entering into an entirely new area of how to treat patients with pulmonary arterial hypertension. Thank you very much for having me virtually, and I'm looking forward to the discussion after the end of the session.
Thank you, Marius. As usual, clear and up to the point. Thank you so much. We will move to the next speaker. Will be introduced by my colleague, please.
Please welcome Dr. Iona Preston. She's a consultant in pulmonary and critical care medicine. She's associate professor of medicine in Tufts University. Please, the floor is yours.
Here we go. Thank you so much for inviting me. It is an absolute pleasure to meet new friends and to see again old friends. And I would like to congratulate the organizers for such a wonderful symposium. So let's move on to the Soteria interim analysis, which is an open label study for sotatercept in pulmonary arterial hypertension. Both Paul and Marius very eloquently introduced the mechanism of action and also the principal randomized trials that studied the efficacy and safety of sotatercept in group 1 PAH. Now let's look at the long-term safety and tolerability of sotatercept. These are my disclosures, and I will move quickly to the design of SOTERIA. So based on the very strong positive results of the phase 2 trial, PULSAR, there was a concerted effort to design a very detailed and comprehensive development program of sotatercept in group 1 PAH. Therefore, the studies that have been conducted and are still being conducted are explained here. So SPECTRA was a cardiopulmonary exercise study that was finished. PULSAR was a phase 2 trial. STELLAR was the phase 3 trial. These 3 trials have concluded. And then the 2 ongoing trials, which are ZENITH and HYPERION. And we can go into details in the discussion if you're interested in more details. So patients who have finished one of these parent studies were offered enrollment in SOTERIA. Those who were unblinded, so they have finished the study and they were already on sotatercept from the parent study on 0.7 milligrams per kilogram every 3 weeks, rolled over on the same dose. Those who were unblinded on placebo or less than 0.7 milligrams per kg were started on the low dose 0.3 milligram or the current dose in the study. And those who rolled over from the blinded ongoing randomized trials, such as ZENITH and HYPERION, not knowing what they had been on the parent study, they were started on 0.3 milligrams per kilogram every 3 weeks on background therapy. Any of these patients who ended up in SOTERIA on the lower dose, lower than 0.7 of sotatercept, were up-titrated to 0.7 milligrams per kilogram every 3 weeks, as long as their hemoglobin and platelet levels were stable. The primary endpoint of the SOTERIA study is to evaluate the long-term safety and tolerability of the drug, but with many secondary objectives of assessing continuing efficacy. The full analysis for this interim analysis had the data cut off November the 8th, 2023. So let's look at the baseline demographics and clinical characteristics of the first 426 patients who had already been enrolled in the long-term trial. Like in the parent trials, patients were almost 50 years of age on average. The majority were females and had idiopathic PAH. The second most prevalent population was, the connective tissue disease associated PAH, 17.6% of patients. And this is a little bit different than the STELLAR and the PULSAR trial, which had a lower number of connective tissue disease patients. So I think with SOTERIA, we will start gaining more experience in the treatment of connective tissue disease associated PAH. There was a minority, but significant minority of patients with hereditary PAH. The majority of patients were functional class 2 and 3, and they were heavily treated on background therapy, triple therapy, or double therapy. So if we look at the summary of overall safety and tolerability, the 3 columns are broken down for the type of patients who entered the SOTERIA trial, but all the safety and tolerability profiles are very similar, so I would recommend looking at the 4th column of all 426 participants. So if we look at the Total exposure was almost 1,000 patient years. And among the treatment emergent adverse events, those that were related to treatment that led to treatment discontinuation occurred in 3.5% of patients, in 15%. Among the serious adverse events that were related to treatment were only 2.6%, and those had to discontinue the treatment. There were 12 deaths in the Soteria. None were related to treatment, and among those 12 deaths, there were 2 GI bleeds, again, not related to treatment per the evaluation of the investigator. So, next step we took to look with great attention to selected adverse events of interest, and starting with bleeding events. If we look at the bleeding events, the majority were non-serious events and were related to epistaxis. Among the serious bleeding events that were related to treatment, there were only 4 patients. 2 of them only had to discontinue the treatment, and that represents 0.5% of the population. Among the serious bleeding events, by looking at the terminology and the definition of the bleeding events, there were 8 gastrointestinal hemorrhages. 7 of those were not related to treatment. Moving on to the next set of adverse events of interest, as Paul mentioned, sotatercept has been initially studied as an anemia drug, so there was an increase in hemoglobin, but there were none of these events were considered serious adverse events, and none of the patients had to discontinue due to an increase in hemoglobin. Thrombocytopenia occurred in 6.1% of patients, and this is very similar in percentage with what we found in STELLAR, which was, I think, around 8%. There were 3 serious events of thrombocytopenia that led to discontinuation of the treatment. And lastly, telangiectasia, an event that we learned during PULSAR and STELLAR trial, occurred in 17.4% of patients who entered from the entrance to Soteria study, but only 1 had to discontinue, and none of these events of telangiectasia were considered serious. Moving on to summarizing the clinical worsening events, there were 20 clinical events that were recorded in this open label trial, and then the lower part of the table summarizes the deaths, worsening related listing for lung transplantation, initiation of rescue therapy, or increase in prostacyclin infusion by at least 10%, PAH-related hospitalizations, and deterioration of PAH. None of these events were related to treatment. And clinical efficacy measures have been recorded at baseline compared to 6 months in the green boxes and 12 months, a year, in blue boxes. And we measured change in 6-minute walk distance from baseline entry into Soteria, change in NT-proBNP, the percent of patients who improved or maintained functional class 2 from baseline, and the percent of patients who met the criteria for low French risk score. And as you notice, all 4 measurements of clinical efficacy that have been achieved at 6 months were maintained at 1 year. Changes in background PH therapy were recorded, and we took a detailed attention to recording these changes. If we look among the 426 patients, we had 286 patients on any form of prostacyclin. And among those, 13 patients discontinued the treatment of prostacyclin, and another 23 patients were able to decrease their dose. Among the 163 patients on parenteral prostacyclin, 10 were able to de-escalate to either an oral form or an inhaled form of prostacyclin. And other changes in the non-prostacyclin background pH therapies were also recorded. Some patients had increases, some had decreases, and some required additional therapy. So I think in the summary, we can conclude from this interim analysis that the long-term treatment of sotatercept of almost 1,000 patients' years of exposure was generally well tolerated, with less than 5% of participants with adverse events leading to treatment discontinuation or death. There were telangiectasia events, but none were serious, and only one patient discontinued. Among the thrombocytopenia events, less than 1% of participants had serious events of low platelets. And regarding bleeding events, most were non-serious epistaxis events. 5.2% had serious events, but less than 1% led to treatment discontinuation. We saw improvements in clinical efficacy that were achieved at 6 months and maintained at 1 year. And while on sotatercept, 16% of patients were able to discontinue or de-escalate their prostacyclin treatment, and another 8.5% had other PAH therapy dose decreased. 3.8% of patients required intensification of their prostacyclin dosing. And knowing that this is an ongoing study and for a few more years with more patients that will roll over into this open label, we conclude that the interim results support the long-term durability of clinical benefits and manageable safety of sotatercept for the treatment of PAH. And I would like to conclude thanking my co-authors, the investigators, the site staff, and first and foremost, our patients. Thank you.
Thank you, Dr. Iona, for this informative presentation. Please join us. And we'll start taking questions from the audience.
Let me start with a question, Paul. These cytokine growth factors have many signaling pathways. Some of them are actually complex ones. So what's your role as a scientist to choose the most likely pathway that will be mostly implicated in the pathogenesis of the disease, and hence maybe the development of the target therapy? I know it's a big question, but just to enlighten the audience.
Usually we want to find pathways that have the most central effect in the pathogenesis. But in a pathway like this, if you start with the human genetics and you see that many of the ligands and many of the other receptors are implicated, it's hard to be as specific right from the start. So I think that the approach with sotatercept was a nice broad approach, and even though we've tried to refine which of the ligands are more contributory and haven't been able to home in on just one or two that are responsible for the majority of the effect, I'm hopeful that we can still refine this activity over time, and it's a reiterative process.
Thank you for the speakers, really great talks. So my question maybe to Prof. Hooper, in terms of the clinical practice for the sotatercept, shall we consider it as a fourth line of management, or maybe someone can argue that we can use it, we can consider it as a first line of management?
I don't know if Marius would like to take this question.
Yeah, this has been addressed to me, so I hope you can still hear me. Sotatercept has not been studied yet as first-line treatment. It's highly efficacious, and eventually I think we will see some data, but right now I think the treatment paradigm for PAH will shift. PDE5 inhibitors and ERA will remain the initial first-line therapy. This is a highly efficacious, well-tolerated treatment for which we have lots of evidence. However, in all those patients who are on this treatment and are not at goal, I think the next step will be sotatercept, not a prostacyclin for the majority of patients. There are, of course, some patients with very severe pulmonary hypertension, very low cardiac output, where one might consider starting a prostacyclin first, then adding sotatercept and hoping that one is able to down titrate prostacyclins again. But the majority of patients, the second step is sotatercept. And the second step will not take place after 1, 2, 3, or 5 years. I think it will take place after 3 to 6 months once the initial treatment has been initiated.
Thank you.
Dr. Ayman, please.
Good morning. I would like to thank all the speakers. Actually, my question is related to the first one. There is some accumulating data that sotatercept is working on the left side, and there is some reports of decreasing the remodeling of the left ventricle. So don't you think that our intention to make the drug as an add-on is not enough? We need to start with this drug, especially in cases with comorbidities, like the cardiac comorbidities, because the reports are accumulating not only in HFpEF, in HFrEF also. There is some benefits from the drug in animal models.
I can take, you may be right. There's still more knowledge that we have to learn. However, when we looked at the stellar sub-analysis, it's a post-hoc analysis. We looked at patients who had 1 or 2 comorbidities or 3 comorbidities. And in this post-hoc analysis, it seemed that the results, the efficacy is similar to patients who do not have comorbidities. In addition, there are some data that suggest that it may work in group 2 PH due to diastolic heart failure, and this is a study that's ongoing. We will have more results when the Cadence trial will conclude. But I think with or without comorbidities, this drug seems to be efficacious.
Doctor there, please, go ahead.
Thank you. Hassan Naeem, Cleveland Clinic, Abu Dhabi. First of all, thank you for this great conference, and happy to, would like to have a question mostly for Dr. Iona Preston regarding the telangiectasia. This seems to be an evolving issue, and the question I have is, you mentioned in the extended late phase study that those patients are having some GI bleeding. The question is, how do we know when you say there is no, not related to telangiectasia? We know our patients with HHT and PH, some of them really die from massive and intractable GI bleeding. So can you elaborate on the telangiectasia, whether it's cutaneous, gastrointestinal, mucosal, and...
Right. It's a very good question. So among all the patients who had telangiectasia so far, they didn't seem to have also a GI bleed in addition to their telangiectasias. Is the occurrence of GI bleed due to occurrence of AV malformations or telangiectasias in the GI tract? This is difficult unless the patients are scoped and we have the results, and being an open label, we were not able to capture all the information. However, we will have a detailed explanation and look at all these patients to make sure we better understand who is at higher risk. Can we identify those patients in whom we should have reservations to start sotatercept? But so far, there has been no indication that there is a correlation between the presence of telangiectasia, which seems to be a mild occurrence and non-serious, and a small occurrence but real of GI bleeds.
Thank you.
Christine?
Hi, thank you. Kristen Highland, Cleveland Clinic. Kind of along that same theme, is there any, has there been any post hoc analysis on the CTD cohort in regards to efficacy or adverse events?
Not yet, but it will be in the paper. So we don't have information as of now, but we will look very carefully at several subpopulations: the connective tissue disease patients, the patients who have been on anticoagulation, where in the STELLAR trial, and Marius can elaborate, we have not seen an increased risk of bleeding if patients are on anticoagulation or not. But if you think about the side effect profile, it's somewhat similar to prostacyclins, which decrease the platelets, increase some risk of bleeding. So I think we know how to look for and be vigilant.
3 more short questions, please. So Nasser, Majdi, and then our colleague there.
Thank you. In fact, my question already answered by Lona, but I'm not convinced in regard of not related, both the GI bleed and telangiectasia. Thank you.
Thank you. Well, Nasser is not convinced, but Marius, you want to answer? Maybe you can convince him about the GI bleeding and potential having telangiectasia in the GI system.
Yeah, I think this is what we all believe, that there is a potential. And again, the case report has been published, which is highly suggestive that it was truly causative. What we need to know is how many patients it's going to affect, how severe it is, how much time it takes, how interventions work. This is all something that is still obscure. I mean, we have patients now on 3, 4, 5 years on therapy, and so far it doesn't seem to be a major issue. But again, it's only a limited period of time. We just need more time, more data.
Majdi, please.
Thank you, Marius. This is Majdi. Marius, I do have a problem in the mechanism of action and the outcome with sotatercept, a drug that dropped the pressure without improving the cardiac output. Simple physics mean that it has a negative inotropic effect on the heart. Now, is that a problem when it comes to adding the drug to advanced cases with already low cardiac output? So now you are using the drug as an add-on therapy for somebody who is not controlled on double orals, low cardiac output, and now you are using a drug that has no impact on the cardiac output. So how would you solve this really puzzle?
Hi, Majdi. The question is excellent, and your concerns are expressed by many people. I'm not so concerned about this because in our program we have about 40 patients in the sotatercept program, and they're doing incredibly well. So, and just from the clinical perspective, it's something I'm not concerned about. It's something we need to understand. First of all, you said improving cardiac output, and I think this is a misconception. The mean cardiac output of the patients who entered STELLAR, or the cardiac index, I should say, was 2.7 liter per minute per square meter, which is normal. Back from the times when we used prostacyclins, we believe that the cardiac output has to be, or the cardiac index has to be at least 2.5, 3, sometimes even higher, and we pushed it higher. And I think it's not a good thing. No heart likes to be pushed like that. What we see when we get the patients put the patients on sotatercept is what I showed you. The heart looks much more happier. It's in better shape. It's smaller. Contractility seems to be much closer to normal than it was before. And everything is just purely unloading. So I think there is no effect on inotropy. I think if we were able to measure the sympathetic nervous system activity in a reliable way, we would find that there's much less sympathetic nerve system activity in those patients. This is just my speculation here, but I think this is one of the key points here. And there are certain patients starting at a very low cardiac output who improve the cardiac output, but not to a near normal level, and not what we saw with, for instance, prostacyclin treatment. And this is something we need to better understand. But all the science that we have so far is that it doesn't seem to be a problem. It, again, just needs to be something that we need to better understand.
Thank you.
Thank you so much, Marius, and I really encourage everyone to interact. I'm sorry, we really have to break because next session we have also a remote talk, so we don't want to keep him waiting. So we have a break for 15 minutes. We're already only 10 minutes behind our schedule, so please come back at 9:55, sharp on time, please. And I encourage you, if you have more questions, to interact with our speakers throughout the day, during the breaks. Thank you so much.
tell me that you want me to be with you every day and every night. And you keep telling me exactly what I wanna hear. Oh yeah, baby, I want you. I will always promise you 1,000,000 sweetest nights. You bring me light and I'm blinded when you shine. You're my light, sweetest candy in the night. Love me, baby, 1,000,000 sweetest nights. 1,000,000 sweetest nights. You're my sweetest love. The night is so good. You give me love, and I don't feel alone. Isn't it right? Every time you phone me and you tell me that you want me by your side. Isn't it cool? Every time you call me. Isn't it right? Every time you phone me and you tell me that you want me by your side. Isn't it cool? Every time you call me, and I feel that I'm gonna be there by your side. You tell me that you want me to be with you every day and every night. And you keep telling me exactly what I wanna hear. Oh yeah, baby,
Still not sticking. Testing 1, 2, 3. Yeah, that sounds good.
Professor Luke Howard. He's a consultant pulmonologist and professor at the Imperial College Healthcare NHS Trust. He will be talking today about the seralutinib, the TORREY trial, and the PDGF pathway. Prof. Luke, the floor is yours.
Thank you very much. I just hope that's working all right. It seems to be dangling around a bit, but anyway, I think you can hear me okay. So thank you very much to the organizers for inviting me back. It's great to be here. I always say this, it's more of an honor to be invited back than be invited in the first place. It means they liked you last time. So I'm going to be talking about the PDGF pathway. We've heard a lot about BMPR2 pathway, TGF-beta pathway in the first session. We're now going to be moving on to another very interesting pathway. Here are my disclosures. So we know that inflammation, proliferation, and fibrosis are three key components of the pulmonary vascular remodeling process. in pulmonary hypertension, and that this can lead to significant changes in the pulmonary circulation, an increase in pulmonary vascular resistance, a decrease in pulmonary artery compliance. We heard about that in the last session as well, which causes right ventricular hypertrophy, which is an adaptive process, but then this becomes maladaptive, and patients ultimately progress to right heart failure. And what we're trying to do ultimately now with the new drugs in pulmonary hypertension is reverse this remodeling process. So we're looking for more than just pulmonary vasodilator therapy to reverse and improve right ventricular function and ultimately improve outcomes for our patients. So what is seralutinib? Well, it is a small molecule that is targeted against three key molecular pathways involving PDGF receptor alpha beta, CSF1R, and the c-KIT kinase inhibitor. Now, it's a new mechanism of action that targets these three key processes: inflammation, proliferation, and fibrosis. And what's interesting about this drug, I think, compared to probably pretty much most drugs I can think of that have either used or been trialed in pulmonary hypertension, is that it's been intentionally designed for PAH. It's not been repurposed for anemia or cancer or for heart failure or hypertension. This has been designed for PAH, and so this is the first time it's been used in humans, is in clinical disease, is in PAH patients. It's also been designed as a dry powder inhaler, so not only is it a new molecule for PAH, it's also an inhaled therapy. So when we compare it against another famous TK inhibitor, imatinib, how does it stack up in the lab? Well, it appears to be roughly 13 to 20 times more potent at inhibiting proliferation of smooth muscle cells from the pulmonary artery and human lung fibroblasts. So when you compare it to imatinib at lower doses, it has the same potency, or so it's greater at the same dose. And when tested in animal models, and we heard a really lovely presentation from Paul Yu in the first session, looking at the relevance of animal models and potentially how this can link into human studies. So this has been demonstrated to be effective in 2 preclinical animal models, showing improvements in cardiac hemodynamics, NT-proBNP, and also in the important aspect of reverse remodeling of the pulmonary vascular bed, and also improved inflammatory biomarkers, so demonstrating target engagement. And when you look at the fact that this is supposed to be a drug that's delivered direct to the lungs, what do we see in terms of spillover into the systemic circulation? Well, on the left-hand side, you can see the difference between the concentration of drug in the lung, in the solid line, and on the dashed line, concentration of drug in the systemic circulation. And that's a logarithmic y-axis, so you're looking at a 10-fold difference between what's in the lung and what's in the systemic circulation. And then in healthy human subjects administered in a BD regimen, you can see that there's a rapid spike in systemic levels, but these tail off very quickly over the course of a matter of hours in the systemic circulation. So there's minimal systemic exposure, and if you look out at day 7 in blue, it doesn't appear to be cumulative. So that's the basic science done and the background. Now into the meat of the presentation, which is the TORREY study, which is a phase 2 clinical trial. Fairly typical in terms of patient inclusion and design. WHO Group 1 patients with PAH walking between 150 and 550 meters, functional class 2 or 3, standard of care background therapies apart from inhaled prostacyclins with a PVR of more than 400 dynes or 5 Wood units. Anticoagulants were also excluded given the background history of what we know from imatinib, and the primary endpoint was change in pulmonary vascular resistance at week 24 from baseline, with secondary endpoints being 6-minute walk distance, NT-proBNP, echo measurements of right heart structure and function, and of course safety events. And other hemodynamic aspects looked at were pulmonary artery compliance, as well as cardiac index and so on. You can see on the right-hand side that were 80 patients randomized 1-to-1 placebo to seralutinib, and you can see the schedule of events down at the bottom there, and there was also functional respiratory imaging, which Adi Gafrani is going to talk about after me. Patients started on 60 milligrams twice daily, and after 2 weeks escalated to 90 milligrams as tolerated. And then at the end of the 24 weeks, patients were enrolled into an open label extension. Here are the baseline demographics. You can see that patients just came in just shy of 50 years old, predominantly female. There was also an exclusion of men of not reproductive age, we're all reproductive, right? But I think up to the age of 50, if I remember correctly. You can see, looking down, 8 to 9 years since diagnosis, so fairly similar to the PULSAR study that we were looking at just now. Roughly half of the patients IPAH, but also some HPAH in there, as well as connective tissue disease. And then looking at the functional class, there does seem to be a bit of an imbalance there with slightly more functional class 2 patients, almost 70% functional class 2 in the seralutinib arm. So that's quite a big difference there. The PVR was pretty low here on average, around 670 dynes, and the 6-minute walk distance over 400 meters at baseline. The patients were quite heavily pretreated. You can see that 43% of patients, 57% of patients were on 3 therapies, and parenteral prostacyclins were around 44%. So heavily pretreated, quite a mild cohort, and quite a prevalent population. So the primary endpoint was met with a placebo-corrected change of 96 dynes and an improvement in PVR just in the seralutinib arm of around 12 or 13%, so 75 dynes, just under a Wood unit. And in a pre-specified analysis, you can see that there is a greater placebo-corrected improvement in pulmonary vascular resistance in the functional class 3 patients. So the worse you are, the more you seem to gain in terms of PVR benefit. Looking across the board on this forest plot at these other pre-specified endpoints, you can see that seralutinib was favored across all the various background ways of slicing up the demographics. But there are 2 things I want you to look at. One is the functional class, right down near the bottom, third from bottom, and you can see here an improvement in PVR in the functional class 3 patients, which I've just shown you. And remember that we saw many more functional class 2 in the seralutinib arm. And then the last thing at the bottom is the REVEAL score. So if your REVEAL score was 6 or more, there did appear to be a much greater benefit of seralutinib over placebo. Looking now at the secondary endpoint of 6-minute walk. Now, do remember that this is not powered for 6-minute walk, and there was no difference in the overall population. But when you look at the functional class 3 patients, there was a significant improvement, p.0476 of 37 meters, so quite a substantial improvement in 6-minute walk. And this was not just related to a placebo decline, there was also an improvement in the active arm. We saw this mirrored in the NT-proBNP. This is always your go-to, really, because there's nothing you can do to really affect this measurement. There's no human error involved, and you saw a drop in NT-proBNP quite early on, which was maintained, and a placebo-related decline, which fits with the whole story of all the other endpoints that you look at. More detail on the hemodynamics. There was a drop overall compared to placebo of around 5 millimeters of mercury in mean PA pressure. In terms of, you saw some deteriorations on placebo, a drop in stroke volume, cardiac output in placebo, which was not seen in seralutinib, so that was protective. And there was an improvement in pulmonary artery compliance on seralutinib, an actual improvement there with no change in placebo. So what about looking at some non-invasive measures here, so echocardiography, trying to get a handle on this concept of right ventricular to pulmonary artery coupling. So there was an echo arm to this. So patients were examined at baseline, halfway through at week 12, and at the end of the study at week 24. These were all blinded analyses in a central laboratory, using and particularly focusing on right atrial area, right ventricular free wall strain, and then this ratio kind of linked to coupling of free wall strain against systolic PA pressure, with this measurement taken from right heart cath to improve the accuracy and also the numbers. The baseline characteristics between the two, there's a lot of numbers here. There's no great difference between the two arms, placebo and seralutinib. What I really want to show you is actually what happened. Now, again, in keeping with some of the other data, we saw deteriorations overall in the placebo arm. So this is right atrial area you're looking at. You see a deterioration there, and seralutinib appeared to be protective against that both at week 12 and at week 24. Looking at the free wall strain, so the more negative your strain, the better. Again, there was a deterioration, so it was becoming less negative. So there's a couple of negatives in there, it's a bit complicated, in placebo, and this was protected against in the seralutinib arm. And when you look at this ratio of free wall strain to systolic PA pressure, so with coupling, there was a deterioration on placebo, but none in the seralutinib arm. So it appears to be protective and beneficial in terms of right ventricular remodeling. Here's your best case and your worst case. So in the top, you can see a placebo patient whose mean PA pressure increased by 5, their cardiac output dropped by 3, and the pulmonary vascular resistance increased by 80 Wood units. And in the bottom, you see almost the flip side of that, possibly slightly better, with a drop of 5 millimeters of mercury, mean PA pressure, an increase in cardiac output of 0.6, and a drop in PVR of 1.5 Wood units there, 125 dynes. And so significant hemodynamic differences, and you can see just by looking at this, even I as a pulmonologist can see the colors, the size, the shape, the movement. You can see particularly improvements in longitudinal function and radial function, but this is quantified by the free wall strain. So just a nice sort of single case illustration of the power of this particular measurement in looking at right ventricular function before and after drug. So finishing up with safety and tolerability, there were some signals here that are important. I think we're learning this from these powerful drugs now that they can have off-target effects. So we're seeing small numbers, single digit, in terms of severe treatment emergent adverse events. A couple of liver-related events in there in the 24-week study. In terms of leading to withdrawal, you see 6 withdrawals in the seralutinib arm versus 1 withdrawal on placebo. And sometimes this is due to an abundance of caution overall from the sponsor. But you're seeing, so there are some safety signals in there that we need to be alert to going forward in the phase 3 and also picking up these in the open label extension. There's quite a lot of cough, 43%. But there's quite a lot of cough in placebo too, 38%. So no great differences there. One thing that's interesting is nightmares. 4 instances of nightmares on the drug versus 1 in placebo. That's one thing that particularly caught my eye, I think. But apart from that, I think the events are pretty much as expected. So to summarize, in the phase 2 study, there was a reduction in PVR in what I think is fairly safe to say, heavily treated prevalent patients who are pretty mild. We saw improvements in functional class 3 patients particularly, and those with a higher REVEAL risk score, which is important in terms of the design of the phase 3 study, which you'll see. There were improvements in hemodynamics, NT-proBNP, and echo imaging as well, showing improvement in RV function. So all of those data led to the design and setup of ProSERA phase 3 study, which is just getting going. We've just had our initiation visit, and hopefully we're going to start recruiting soon. And I believe you're going to be recruiting here in the Kingdom too. Yes, Dr. Abdallah is nodding. Okay, thank you very much indeed.
Thank you, Luke. Thank you, Luke, for this presentation. Please join us. I'm not sure if we are up online. We will have Ardi Ghofrani with us. Are we live? It's my pleasure. Is he with us?
I can hear you.
So the next talk will be from our friend and Professor Ardi Gofrani. He is a professor of pulmonary vascular research at Justus Liebig University, and he's the division head of pulmonary hypertension in Gießen University Hospital in Germany. We knew Ardi for many years now, and he's a regular friend and SAPH member, if you wish. It has been a while since we saw him in person. It's always good to see you, Ardi. Please enlighten us about the sub-study of the Touré trial about the volume distribution of pulmonary vessels, which is a radiological concept. Ardi.
Sam, thank you very much for your kind introduction. As always, it's a pleasure to meet my friends at SAPH, although this time, unfortunately, it's virtual again, but I promise next time to undertake every effort to meet everyone, wherever SAPH is going to be next year, to meet everyone in person. Also, thanks to Luke Howard, my right honorable colleague and friend from Imperial College, for introducing the results of the Touré study, which makes my life easier because I don't have to explain to you seralutinib and its mode of action anymore, and you've seen interesting efficacy data. And my task now is to share with you some indications of blood vessel volume distribution improvements that were taken from a sub-study conducted during the phase 2 Touré study. So I think we are all in agreement that CT scanners are very important diagnostic tools in our hands when looking at the organs of our patients. However, most of the times, visual examination is the only thing which happens during the analysis of the gathered images. It depends very much on the individual skills and experience of our radiology colleagues. It is also true to say that very small abnormalities or even a three-dimensional reconstruction of the images is mostly happening in the brain and recollection of our clinical colleagues rather than being quantifiable or even comparable between individuals. That's why Fluida, a company that deals for a long time with the offline analysis of imaging data, has developed a algorithm with which we can, as clinicians and each hospital can do that, upload images to a server and then with the help of AI technology, analysis of images and reconstructions, 3D reconstructions of these images can be performed. It's important to mention that for the sake of this analysis of functional respiratory imaging, non-contrast enhanced high-resolution CTs can be utilized, and then they are reconstructed in 3D with high resolution, even being able to distinguish between precapillary arterioles and postcapillary venules, apart from also the airways and other structures that are seen here on the right-hand side. So for the sake of the analysis of pulmonary vascular vessel area, as well as the volumes, and particularly focusing on small vessels versus more centrally located vessels, it has been chosen to take vessels with a cross-sectional area of 10 millimeters mercury square and more, as compared to small vessels with a cross-sectional area of 5 millimeters square, so-called BV5 section, as opposed to the BV10 section. And there's a normal distribution in unaffected healthy people who usually is quite constant and may deteriorate a little bit as a function of aging, but nevertheless never gives an indication of loss of precapillary or smaller pulmonary arterioles, neither indication of constriction or even remodeling. However, in patients with pulmonary arterial hypertension, we know from histology, which cannot be performed in our patients, only post-mortem, but also from animal models, that most of the disease is really focusing on a pruning of pulmonary vessels and remodeling of pulmonary vasculature at the level of smaller pulmonary arterioles and precapillary pulmonary resistance vessels. So the CT measure of small vessel volumes correlates with small blood vessel wall area on histology, and this could be shown during the validation of this technology. So to visualize what I've been just talking about, when we talk about a region of blood vessels with a cross-sectional area of 10 millimeters square, we are pointing at segmental and subsegmental pulmonary vessels, while the region that is of interest in the course of pulmonary arterial hypertension is located more in the periphery of the lung, and this region is the so-called BV5A section. And as a consequence of the disease, these vessels become more restricted, and they prune, and they also lose blood vessel volume, cross-sectional area, on the expense of ratio increase towards the larger blood vessels. So using thin slice CTs and from patients with pulmonary hypertension, the purpose was to provide evidence consistent with a reverse remodeling effect of seralutinib. And the hypothesis was that the volume of distal pulmonary arteries relative to the volume of proximal pulmonary arteries will be increased by seralutinib, as expressed by an increase in the ratio of BV5 to BV10 pulmonary arterioles. So this functional respiratory imaging sub-study was conducted in conjunction with the TORREY study that Luca just presented to you. And you may appreciate that images were uploaded from the time point at baseline and then reanalyzed after 24 weeks of treatment with either placebo or with seralutinib. The thin section volumetric non-contrast chest CTs were obtained, and as mentioned before, it was followed by automated pulmonary vascular segmentation. The baseline and week 24 blood vessel volumes were determined at distinct levels, so an investigator bias during the analysis could be excluded. The blood vessel volumes of pulmonary arteries with a cross-sectional area of less than 5 millimeters square and 10 millimeters square were calculated, and a ratio was calculated from those measurements. A linear regression model was used to assess the treatment effect. This is the baseline demographics of the patients that were included into the sub-study, into the imaging sub-study, and it roughly corroborated the data of the overall patient population with an age a mean of around about 50 years, with a high proportion of female patients, with a slight imbalance regarding the patients who were treated with seralutinib as opposed to the placebo patients. And there was, compared to the overall TORREY study, also a predominance of patients with functional class 3 as opposed to patients with functional class 2. We just heard that the proportion was reverse in the overall patient population, so we might keep that one in mind. Nevertheless, with this very elegant imaging technology, as we first may focus on the patients who were treated with placebo and compared to 24 weeks, there was no change in the BV5 to BV10 ratio, while this ratio was beneficially influenced and increased in patients who were treated with seralutinib. And on the right side, you may see the individual changes in the BV5 to BV10 ratio in seralutinib and placebo patients, respectively. There were also interesting correlations that could be retrieved. So when the change in the BV5 to BV10 ratio was correlated to changes in pulmonary artery compliance, meaning that improvement in pulmonary artery compliance is usually regarded as a good thing for our patients, showing that there is a better coupling of the right ventricular function to the afterload in the pulmonary artery. This could also be correlated to improvements in the blood vessel volumes in the small pulmonary arteries. And the same was true for the stroke volume, which also showed a nice correlation. And this is to visualize what I just previously shared with you in numbers, and pictures and images sometimes speak more than 1,000 words, as they say. And as an example, on the left-hand side, this is an example of a patient treated with placebo. The pulmonary vascular resistance was rather increased despite background therapy with PDE5 inhibitors and prostacyclin derivatives. And this was also then by means of FRI reflected by a reduction in the BV5 to BV10 ratio. And this is a enlargement of the right lower lobe, showing that there is virtually there is no improvement, rather than even a slight loss of blood vessel volume in the periphery of the lung. On the right-hand side, a seralutinib-treated patient that received a drug and where the pulmonary vascular resistance was reduced by 1.6 Wood units, and respectively the BV5 to BV10 ratio increased. And you may appreciate that compared to baseline, there was an increment in peripheral blood vessels filled with blood. And this is not to say that the improvement was only seen in the upper right lobe, but it could also be observed in the entire lung, but this is for the sake of visualization. So in summary from this FRI sub-study, it can be stated that seralutinib treatment resulted in a significant improvement in the ratio of blood vessel volume in distal vessels relative to the larger vessels, consistent with a return towards a more normal blood vessel volume pattern. The BV5 to BV10 ratio correlated with important measures of right ventricular pulmonary artery coupling as measured by pulmonary artery compliance and stroke volume. And to increase our understanding of the effects of seralutinib on pulmonary vascular patterns, the same kind of sub-study is planned for the phase 3 PROSERA trial, which I am using this opportunity to familiarize you briefly with the study design and where it's going to be conducted. So this study will be a randomized double-blind placebo-controlled study. This will be the pivotal study to seek approval with the authorities. 350 patients will be recruited at roughly 106 sites. There will be a one-to-one randomization to either receive seralutinib or placebo BID by dry powder inhalation. And we will see the typical patient characteristics being included. The primary endpoint will be evaluated at 24 weeks, continued by an open label extension period during which more important safety and efficacy data will be collected. And Luke already pointed out the fact that luckily and to all our delight, Saudi Arabia will also represent the region inside the randomized placebo-controlled global study. The primary endpoint in this study will be the change from in 6-minute walking distance from baseline to week 24, as in many other registrational studies. And the key secondaries will include time from first dose to first event of clinical worsening, and an improvement score, which includes the prevention from deterioration of WHO functional class, decrease in NT-proBNP, and also an increase in 6-minute walking distance, as well as changes from baseline to follow-up in NT-proBNP. Also, the REVEAL score will be used to assess the risk scores. And of course, and very importantly, safety will be analyzed thoroughly, and as an exploratory sub-study, plasma concentrations of seralutinib will be used to model the pharmacodynamics of biomarkers measured in the blood. The FRI sub-study will include 77 patients at already identified eligible 50 sites globally. And as shown before, the objective will be to evaluate the effect of seralutinib versus placebo on changes in the pulmonary vasculature. Endpoints will include the pulmonary vascular blood volume, the blood volume as a percentage of total lung volume fibrosis score, because we just heard from Luke that this drug may also have anti-fibrotic effects, and also an image-based ventilation to perfusion score from baseline to week 24, which is doable with this advanced technology. With that, I'd like to close. Happy to receive any questions, and I will then stop sharing my screen.
Thank you, Ardi. I believe we will take questions after the third talk, but thank you so much for this elegant talk.
Now it's my pleasure to introduce Dr. Faisal Al-Andajani. He's a physician scientist and pulmonary hypertension assistant professor at King Abdulaziz University Hospital. He will be talking about cardiac MRI and risk stratification of PAH. The floor is yours.
Assalamu alaikum wa rahmatullah, and good morning, everyone. Assalamu alaikum wa rahmatullah, and good morning, everyone. Thank you, Dr. Nora, for the kind introduction. And also, I would like to take this opportunity and thank Prof. Al-Dal'an and Mr. Hassan for inviting me. Even though this is, I'm not an expert in this field, and I just joined the SAPH committee, but they were very kind to invite me to share my story in regards to right atrial area, cardiac MRI, and risk classification in PAH. So the objectives of this talk is to learn the previous and the current strategy we have when risk classifying patients with PAH using cardiac MRI, and to look at ways to assess the current cardiac MRI risk stratification methods for PAH. And finally, understand the impact of refining cardiac MRI thresholds for risk assessment. So PAH is a severe life-threatening condition that can worsen with time if untreated, and can cause continuous and progressive increase in pulmonary vascular resistance, which may lead to right ventricular failure and death. Generally speaking, we can measure the heart and its surrounding blood vessels using both radiological and non-radiological methods. However, today, our focus will be on cardiac MRI. In 2015, the European Society of Cardiology and European Respiratory Society guidelines stratified patients with PAH into 3 risk groups: low, intermediate, and high, of 1-year mortality, based on a combination of clinical, functional, exercise, biochemical, imaging, and hemodynamic variables. And please note that the majority of these variables and cutoff values were based on expert opinion. So in several registries, the 2015 risk assessment tool has been validated in simplified versions and showed that it can be used as a reliable tool to help predict outcomes for patients with PAH. For example, the French, the Compera, and the Swedish registries All three registries provided the value of achieving a low-risk group. In addition, validation cohorts from the US showed the REVEAL 2.0 risk calculator and the REVEAL Lite 2 were accurate and well-calibrated, confirming the generalizability of the 2015 guidelines. Although an extensive body of literature has showed that cardiac MRI RV measurements are prognostic and have utility in risk classification, however, the 2015 guidelines were only including RA area, but not RV measurements. And at that time, there were limited data on RA area measurement, and no study has assessed the accuracy of RA area thresholds to assess risk of one-year mortality. During my PhD studies, one of the main objectives of my thesis was to published in early 2022, was about comparing RV and RA area measurements and their utility to risk stratify patients in PAH. And this was done by comparing published thresholds for RV metrics with the RV metrics and with the 2015 thresholds for RA area. We included a total of 311 consecutive treatment-naive patients from the ASPIRE registry, and 121 patients underwent cardiac follow-up. Using the ESC-ERS RA risk thresholds for one-year mortality, RA area stratified patients into intermediate and high risk at baseline and follow-up, but wasn't able to identify a low-risk group either at baseline or follow-up. In contrast, using previous published thresholds for RV measurements, 3 of the RV measurements identified low and high risk groups at baseline and follow-up. Also, RV ejection fraction was able to identify low, intermediate, and high risk patients at baseline and intermediate and high risk patients at follow-up. So when comparing the RA area with percentage predicted RV end systolic volume index on the survival curves, we can see that the RV metric shows better stratification than RA area, both at baseline, follow-up, as well as risk transition. So this study highlighted the need for the 2015 ESC-ERS guidelines to include measures of RV functions rather than RA area alone, to aid risk stratification in PAH. So when the 2022 ESC-ERS guidelines was published, they actually included RV measurements for the risk assessment. Also, if you look closely at the comprehensive table, the other thing that was updated in the risk of one-year mortality, it was increased the greater than 20%, and the burden, the intermediate risk group, 5 to 20%. Although this approach holds promise, its applicability and validity across centers and countries require careful examination. So just recently, around 6 months ago, a paper by Silent et al. Was published evaluating the cutoff values of the current MRI risk stratification thresholds and the need for external validation. They studied incident treatment-naive patients with PAH from the Amsterdam group in the Netherlands, and the analysis included 258 patients treatment-naive and 172 patients with follow-up cardiac MRI. Using the current cutoffs, cardiac MRI baseline, most patients were classified at intermediate risk, which represent 45% of the population, which is almost the half here in the intermediate risk. However, only 11% of the population were classified at low risk, and 44 were classified at high risk at the time of the diagnosis. In the follow-up, 32% of patients were classified at low risk, 45 at intermediate, and 23 at high risk, as we can see here in this figure. Here is the 1-year mortality risk and survival at baseline according to each separate cardiac MRI metric. So we can see at the left-hand side the RV ejection fraction, and in the middle, stroke volume index. And at the left-hand side, we can see the right ventricular and systolic volume index. And it clearly shows that patients with PH at low risk were poorly discriminated from other risk groups. On the other hand, the 1-year mortality risk and survival at follow-up, according to each separate cardiac MRI, showed appropriate discrimination between the 3 risk groups. However, RV and systolic volume index did not identify patients at intermediate risk. Because in this study, the current ESC, ERS, MRI cutoffs were unable to identify patients at low risk, the author explored potential modifications to the cardiac MRI thresholds to enhance their accuracy in identifying patients with low risk. So to determine the optimal right ventricular ejection fraction cutoff, they selected the highest predictive value, and i.e. the lowest p-value of the log rank test for mortality. So we can see here, it's 19 and 44. So, so RV ejection fraction for the low risk group was greater than 45, and between 19 to 45 in the intermediate risk, and less than 19 for the high risk group. And then they applied the refined right ventricular ejection fraction threshold to the they found. And as we can see here, it improved the identification of low-risk patients and survival discrimination, both at baseline and follow-up. However, further validation of this cutoff values is important. So in conclusion, using cardiac MRI, the 2015 ESC ERS RA area thresholds did not identify patients at low risk. On the other hand, RV function measurements were able to identify patients with low-risk mortality. Also, we saw that when validating the current ESC ERS cardiac MRI metrics, patients with low risk were poorly discriminated from the other groups. So refining some current cardiac MRI thresholds improved the identification of low-risk patients, both at baseline and follow-up. However, further validation is needed. And finally, suggestions for future work could be to standardize cardiac MRI protocol across centers for consistent risk assessment, utilize AI, and collaboration and carefully to establish universal application of cardiac MRI thresholds. Thank you for listening all.
Thank you, Faisal. Please join us here. At the end of the session, we would like to open the floor for discussions, and I would like to start by asking one question for each. Luke, how does the molecule get into the, the smooth muscles or the endothelial muscles?
Oh. It's one of those really tricky things, isn't it? You think, right, so you're breathing this stuff in. We typically thought inhaled therapies work on large airways for asthma and COPD, yet now we're saying, well, here's a drug for the pulmonary vasculature. And to defend, I don't think we really know the answer, but to defend the fact that these drugs work via the inhaled route, and it's not just a systemic absorption, I would always turn to nitric oxide, because it has such a short half-life. And when you see a vasoresponder, you inhale, you see a response within a couple of seconds, a true responder. And it's got such a short half-life that it's not that it's getting into the circulation and coming all the way back round. So we know somehow that when you inhale something, that it can work on the precapillary pulmonary arteries, whether it's crossing from the very small airways or in the alveolar space into the pre-ascena pulmonary arteries. I don't know. When you look at imaging studies of labeled drug, you can see that you can see a fairly nice peripheral distribution. Particularly, they've done this with seralutinib. So I don't know the exact mechanism of how it gets there, but we know from other drugs that it does. I think Ardi might also have a comment on this because he's a bit of an expert on inhaled therapies in Geese, and they've done a lot of work on this. So I'm going to look to him for backup.
Sure. So, I mean, he might be able to answer this with my question to him, Ardi. How do we validate the CT images, i.e., how do we know that what we look at is what you told us? How can you really truly validate the images to be accurate representation of the volumes of the blood vessels in the lung?
So first of all, to Luke's explanation, there is little to add because Luke already used a perfect analogy from inhaled nitric oxide, which I would have done as well. The second thing is that so everything that he talked about hypothetically is in fact already shown in preclinical models, in dry lab models using different aerosols with impactation on different levels of airway sizes. It's been used with labeled drugs, and then histology was undertaken. We've used microparticles to show where these inhaled drugs end up depending on the size of the aerosol. But ultimately, it's also important to appreciate the anatomy of the lung. And what we are all, I think, influenced by is this one alveolus, one vessel model, where intuitively it's difficult to catch that something that ends up in an alveolus should in fact basically influence a precapillary vessel, which on this typical descriptions we have in our textbooks seems far away. The reality is that the terminal bronchiolus dives deeply into a convolute of alveoli, surrounded by those same alveoli that it provides airflow to. And with those, there is also the accompanying precapillary arteriole. So the precapillary arteriole, by direct diffusion, receives drug from the alveolar space, diffusing to the outside of the vessel. And if we just continue in this line of thinking, it's even more important to mention that opposite to systemically applied drugs, drugs that are inhaled reach highest concentrations from the outside of the vessel to the inside, where they can display their efficacy in the region of interest, in the cells of interest, and you mentioned fibroblasts and smooth muscle cells, before they then enter the lumen and get diluted and carried away by the blood flow. So this just in completion of what Luke has already beautifully started to explain. And then with regard to the claim that can be derived from the FRI study, I actually did not claim that it in fact is a proof for reverse remodeling or that we regain very small precapillary pulmonary arterioles, but what can be stated is that the blood vessel volume in those peripheral areas is increased, as opposed to a decrease in the congested, more centrally located pulmonary arteries in the BV10 section. And it is an indirect reflection of what we then can see in histology, where at least in precapillary models of pulmonary hypertension, we know that this class of drugs, TKIs, as also shown for sotatercept, for instance, for the activin ligand traps, are able not only to halt the disease progression, but they are in fact, at least in preclinical models, able to reverse the unhealthy pulmonary vascular remodeling and narrowing.
Thank you, Ardi. Last question, I would like to comment from Dr. Faisal about the approach toward using the echo as a proof of concept of improvement with the newer agents. Would it have been better to use MRI study rather than an echo study from what Luke showed us? Just he was trying to tell us what to look at, and I think we've seen it.
Well, thank you for this question, a very detailed question. And as I mentioned in the beginning, I'm not an expert to actually answer fully. But from what I've seen, we can tackle the question of the advantages and disadvantages of cardiac MRI against echo. So echo is feasible, and cardiac MRI is not widely distributed in the hospitals and expensive. So there's patients are not always near to a cardiac MRI to be examined. Yeah. So that's why sometimes echo is much more better than cardiac MRI. Yeah.
So we'll take Abdullah. Go ahead.
Yeah. So Ardi, thank you for your talk. And in fact, you already touched on my answer at the end of your answer previously. So this increase in volume in small blood vessels would be, you can argue, of course, it's maybe halting the progression of remodeling, or maybe even reversing it and recruiting more, or simply because the cardiac output improved, it is recruited more small blood vessels only by physics, by just having an improved cardiac output. What do you comment on this?
First of all, hello, Abdullah. Very nice to see you. I'm very happy to see you in good health.
Thank you.
And regarding your question, I believe that in patients, particularly with severe pulmonary hypertension, how would you call it, distensibility of the vessels, of the precapillary vessels is exhausted by almost 100%. There are physical models that can show, particularly because streaming blood or air always tends to search the way of the least resistance, that vessels in general in these patients are not really distensible by physical force anymore. So lowering the pressures and lowering PVR is a mixture of vasodilatation, of reopening vessels, and of course increased cardiac output. Where we see distensibility and then an increased cardiac output might play a role is in the rather larger vessels. But I think it's also good news to share with you that this technology, if we extend the type of data and image collection from contrast enhanced CT images, which is doable in our patients, as we know, you can then even distinguish the ratio of the inner cross-sectional areas of the vessels as opposed to the vascular wall. And I think this is going to be a future very interesting ratio to look at, admitting that it will not really reach, with the resolution of current CTs, it will not really reach the classical precapillary resistance vessels, usually at a diameter of 100 microns and less.
Thank you. I just wanted you to elaborate on this more. Luke, so we understand that the 50% of these patients were actually, nearly 50% were actually on triple therapy that included prostanoids. And they were very liberal in the 6-minute walk test. So in the enrollment criteria was quite liberal. And the median, the duration for the disease, the mean one is about 8 years for these patients. So would you think that explained the modest, although p-value was positive, obviously, the modest decrease in BVR, which is around 14%, not like what we see in some other studies, 30%, 40%, for example. You think that's the reason? Because of these patients are already on heavy treatment, mean duration is 8 years. Can you comment on this?
I think there are some interesting observations from this trial when you also look back at what we discussed in the first session, which is that we saw in a relatively similar population, I think they're slightly milder than they were in Pulsar and Stellar. There you didn't see so much placebo deterioration. In this cohort, you did see some placebo deterioration. So it's interesting just to look purely at the placebo arms of the two trials and see some interesting differences, which I can't really explain why that might be, because the inclusion criteria shouldn't necessarily result in that. Your question is around the pulmonary vascular resistance, and that's why I did mention in passing the percentage reduction, just purely in the seralutinib arm was about 13%, and the placebo corrected was something like 17 or 18%. And I think once you start to look at where they are at baseline, then that PVR reduction, I think, could potentially be meaningful. Then when you look at the secondary and the exploratory endpoints and you see, particularly in the more severe patients, so you highlight the mild nature of the patients. You take the more severe end, you see improvements in hemodynamics and you see improvements in walk distance and that's allied to improvements in BNP. So I think what those things are telling you, those secondary endpoints, is that this PVR does translate into clinically meaningful benefits, but perhaps we need to just steer ourselves a little bit towards the severer population, which after all is what we do in the guidelines. We take the guidelines and we look at the patients and we say, you're low risk, we don't need to do anything. So that's probably what we need to be doing with our studies, is saying, well, the people we wouldn't do anything for in the guidelines anyway, why would we put them into a trial? Because we don't need to do anything. So I think that's what this is highlighting. And the other thing is, I think we've all been blown away by sotatercept, and we thought that this is the new bar to achieve. I mean, come on, okay, yeah, it's amazing, but let's not forget that the 6-minute walk improvement in functional class 3 patients in the TORREY trial was 37 meters. That's pretty much what you got with the early monotherapy trials, but this is on background triple therapy. So I think the effects are meaningful. And I do think that we shouldn't just be completely dazzled by sotatercept. We heard lots of issues about concerns. We need to keep working on other pathways and applying them in these patients.
Thank you. If I may, the PVR improvement is modest. It's not that what we will expect to see in a clinically significant or meaningful improvement by just improving the PVR by, in the worst case scenario or the best case scenario, 21%. The average was 14%. So do we really expect to see this much of vasculature improvement in the lung and the hemodynamic changes that will be expected from this drug? So again, we start seeing improvement in the clinical condition once the PVR goes significantly lower by 40% or so from other, historically other clinical trials. What do you think of that?
Yeah. So we see improvements here in PVR and also translates into RV function. Now, I think, and this is going slightly answering your question in a different way, there will be some open label data presented I think probably at the ATS. I kind of lost track of how much has been presented in various places. I think there was some presented at PVRI a couple of weeks ago, so I'm at liberty to say, I think that this drug potentially will be more of a slow burn, and that's what you might expect from a non-vasodilator drug. That what you see from 24 to 48 weeks is continued improvement. And so actually you may see a continued further drop in remodeling. I think we need to be patient when it comes to the remodeling process. You don't necessarily get it as an instant hit.
Great, thank you so much. It looks like nobody, Dr. Ayman, want to ask a question? We have a minute or two.
Dr. Faisal, practically speaking, where do you think we need to go for MRI in order to affect our risk stratification in a case of PH?
Thank you for the question. So one of the two things that came in my mind is the thing I mentioned in my last slide is the try to standardize the after process of the processing the cardiac MRI images. So, because what happens is after some centers deal with the after they do the cardiac MRI, they deal with it differently. So, for example, one center include the trabeculations and papillary muscles, and other centers do not include it when they measure the right ventricular insufficient volume, for example. So that's one thing, is to try to standardize the centers when post-processing cardiac MRIs. And the other thing is sometimes the reproducibility and reliability of because if some person takes a measurement and another one takes it can't be different. So it has to be also reproducible and reliable. So one thing we can do is to train the AI, and a lot of groups, especially in the UK and Europe, started that, and we saw good outcomes from that. Yeah, thank you.
Hani, a quick one.
Very quick. So I just want to congratulate you on your excellent paper and the research. You know, emerging data from the region tells everyone that we can do this, and these are complex studies and very complex measurements. I just want to highlight something you just mentioned. The standardization of cardiac MRI is the key component. I mean, it's difficult enough with echo. With cardiac MRI, there's many technical things in post-processing, and I think having the skill sets in the region and teaching our colleagues is really the most important and valuable lesson. I just want to thank you for that.
Thank you, Hani. I would like to conclude the session now, and Procera is coming to Saudi Arabia. We have talked about 2 centers so far, and I think it will be a successful trial in the kingdom. We have the patients for it. Abdullah and myself has already started the meetings with Gusamer, and I think it will be a good trial to be part of. I will conclude this session, and I think Mr. Hassan has some announcements to make.
Yes, please. Today is Friday, and it's by design. We're breaking a little early for the prayer time, and then lunch will be opened at 12:30. So you have about one and a half hour from now to prayer and refresh, come back. 12:30 to 1:30. 1:30 we'll start here, and since there's a lot of talk about the 6 minutes walk, there will be a workshop exactly at 1:30 also in the small break room in the side. Thank you very much, everyone. Lunch is downstairs.
I'm Badr Al-Ghamdi. It's a pleasure to chair this session with Dr. Boussaidi, Nasser Boussaidi from Oman. So this session is going to be the clinical pitch specifically for Group 3, pulmonary hypertension. Just one announcement that we're going to have parallel sessions for the 6-minute walk test. It's going to be starting on the same time at 1:30. And it's a pleasure to introduce the first speaker, Christine Hyland. She is the director for the rheumatic lung disease. In addition that, she's associate program for the research and scholar. She's going to talk about the pulmonary hypertension in chronic lung disease, pathogenesis, and clinical phenotype. Dr. Christine, the floor is yours.
Great. Thank you. Good afternoon. I'd like to thank the organizers and my esteemed Saudi Arabian colleagues for inviting me and having such wonderful hospitality. It was a true honor to be invited. And so with that, I'm going to talk on the pathogenesis and clinical phenotype seen in Group 3. We know that lung diseases are increasing in prevalence, and we haven't made very much headway in treating pulmonary hypertension in chronic lung disease. We have tried a number of our pH therapies with mixed results, and this may be due to a lack of understanding of the pathogenesis and the heterogeneity of the patients that are in this category. Those are my disclosures. And so I will first start with some thoughts on pathogenesis. So the vascular hypothesis in scleroderma has been around for a while, linking vascular injury and fibrosis. We also know that there's increased endothelium in the interstitium of patients with scleroderma-associated interstitial lung disease. And we know that there's increased acute exacerbations in idiopathic pulmonary fibrosis if the patient also has pulmonary hypertension. We know that in preclinical models, prostanoids have antifibrotic effects, and we certainly saw an interesting signal in the INCREASE study with an improvement in forced vital capacity. So taken together, there seems to be some shared pathogenesis, perhaps, between Group 1 and Group 3. So the World Symposium on Pulmonary Hypertension, the first World Symposium, grouped together lung diseases into Group 3, where hypoxia was felt to be the common denominator. However, we know when we give these patients oxygen, we don't reverse their pulmonary hypertension. And we also know that humans are not like our animals that have pure hypoxic vasoconstriction. In fact, unless maybe you're at chronic high altitude. But in fact, these are patients with often systemic disorders where there's disordered immunologic pathways, fibrotic pathways, and angiogenic pathways that result in vascular remodeling. Certainly, with hypoxia, there is vasoconstriction and thickening of the media, but we also have involvement of all parts of the vascular system, not just our pulmonary arterioles, but we have capillary dropout, we have venule involvement with a PVOD-like phenotype, and so the vascular pathology is quite heterogeneous, and this in part is likely why our pH therapies have had disappointing results. And the vascular pathology is quite heterogeneous even within a single patient. In the top In the top left-hand corner, you can see a patient with idiopathic pulmonary fibrosis. The top part, you can see a lot of fibrotic lung, normal lung parenchyma here. And if you look at this pulmonary arteriole, you can see evidence of abnormalities kind of abutting where there is fibrosis, and then the pulmonary artery thins out where there's more normal lung parenchyma. In slide B, you can see in IPF a lot of the smooth muscle hyperplasia within the interstitium. The second row are patients with COPD. Here is someone with moderate pulmonary hypertension, and panel D is a patient with severe pulmonary hypertension, and you can see reduced ERG-stained endothelial cells indicating decreased capillary density in this patient with severe PH. In the bottom left-hand corner, you can see another patient with COPD and PH with severe intimal fibrosis, and you can see vascular remodeling. So this is not just hypoxic vasoconstriction. There is vascular remodeling like you would see in any organ where there is disordered fibrosis, inflammation, and angiogenic pathways. So cigarettes, they obviously are a leading cause of COPD. Our patients with idiopathic pulmonary fibrosis tend to be smokers or former smokers as well. And cigarette smoke can play an independent role outside of causing the parenchymal destruction in pulmonary vasculopathy. They can trigger progenitor cells that result in intimal hyperplasia. There's reduced expression of eNOS. There's increased VEGF expression, infiltration of inflammatory cells, as well as mitochondrial oxidative stress and dysfunction. Hypoxia, which these patients all have, or diseases all have in common, can cause hypoxic-related vasoconstriction by an imbalance of endothelial-derived vasoconstrictive and vasodilator mediators. It also shuts down potassium channels, resulting in an influx of calcium, which can sensitize the contractile machinery in the cytoplasm. Hypoxia also results in increased sympathetic activity. So these patients are at increased risk of cardiac comorbidities. Hypoxia also leads to oxidative stress, metabolic alterations, and inflammation. Hypoxia increases the expression of HIF-1 alpha, and HIF-1 alpha results in increased VEGF. And we've heard this morning already about VEGF and other growth factors that result in cell growth, differentiation, and proliferation. Hypoxia also increases TGF-beta, and we had a whole session on TGF-beta this morning, and TGF-beta is intimately linked with HIF-1 alpha, and TGF-beta is responsible for cell growth, differentiation, and proliferation in almost all tissues. So it's involved in vascular remodeling. It's certainly the target in pulmonary fibrosis. And it also results in overexpression of VEGF and other growth factors. HIF-1 alpha also can lead to mitochondrial dysfunction and metabolic abnormalities. And then there's been increased interest in microRNAs, which are the non-coding RNAs that can bind to messenger RNA and deactivate them. And so together, all this results in the vasculopathy that we see with group 3 pulmonary hypertension. And then we layer on genetic and molecular alterations. In COPD, a 5-HTT gene polymorphism has been identified, whereas on the ILD side, there's been interest in BMPR2. Certainly, the epigenetics of environmental exposures, pollution, outdoor, indoor pollution, as well as cigarette smoking, and the influence of comorbidities in the setting of chronic inflammation, and the mechanical effects of the lungs themselves with emphysema, hypoventilation, fibrosis, altogether results in the pathobiology of group 3 pulmonary hypertension. And this results in pathways that are differentially up and down regulated in COPD and IPF patients. So the pathology of these two different lung diseases can be completely different. PVOD and IPF share anti-inflammatory, anti-angiogenic, and anti-apoptotic pathways, which is almost opposite to the shared pathways of COPD and pulmonary arterial hypertension, which are pro-inflammatory, pro-angiogenic, and pro-mitogenic. So, what does this mean in regards to our clinical phenotypes? Well, connecting the dots is still something in progress. I've stolen this slide, I've adapted this slide from Steve Nathan, who's going to be talking after me. But certainly the challenge as a clinician is to figure out, is my patient more of a group 1 type phenotype, or are they group 3? And I think the reality is this is a spectrum, and often they're somewhere in the middle. Certainly if they have PAH risk factors, we're going to think they're more likely PAH. And if they have severe, pulmonary physiology, we're going to think they're group 3. We've always been taught that patients with group 3 pulmonary hypertension have mild pulmonary hypertension. I don't like the word mild because it implies that this isn't, there aren't severe outcomes. There are very severe outcomes. But the mean pulmonary artery pressure tends to be modestly elevated in group 3 pulmonary hypertension, typically less than 35 millimeters of mercury. And when you see those really high pressures, that makes you think maybe this patient's more a group 1 phenotype. Certainly if you see more parenchymal abnormalities on CT scan, that goes with group 3. And in this situation, a CPET can be useful. Patients that are more group 1 are likely to have a circulatory limitation to exercise, where they have preserved breathing reserve, reduced O2 pulse, low cardiac output to VO2 slope, and their mixed venous oxygen saturation is usually low or at the lower limit of normal, and there's no change or there's a decrease in PaCO2. Whereas patients who are group 3 tend to have a ventilatory limitation to exercise. They have a reduced breathing reserve, a normal O2 pulse, a normal cardiac output to VO2 slope. The mixed venous O2 is usually above the lower limit, and they can develop an increased PaCO2. So these 5 groups that we are stuck with, can be helpful. It can also be a bit of a burden as we try to treat an individual patient. And so the NHLBI Pulmonary Vascular Disease Phenomics Program has attempted to say, can we do away with these 5 groups? Can we more deeply phenotype and endophenotype these patients, getting down to the genome and the protein level? And so there's a cohort of 1,195 patients, comparators, and healthy volunteers, all pH types, and they had a battery of tests that were conducted within 6 weeks: the history, vitals, body impedance, height and weight, quality of life, PFTs, 6-minute walk, echo, cardiac MRI, sleep studies, VQ scans, CT scans, either an invasive or non-invasive CPET. Right heart catheterization with challenges, oxygen challenge, nitric oxide fluid challenge. They had all sorts of labs, and they had omics. And they were followed on a yearly basis. So I'm going to show you data from the PV-Domics data set. We at the Cleveland Clinic had the privilege of being the data coordinating center. And this data, I think, reflects some of what we already know, but there are some insights into the clinical data that might help us, see what a group 1 versus a group 3 patient is. So in our cohort, we had 172 patients that were adjudicated, and these were some lively discussions amongst, a variety of true pH experts. So we had 172 subjects that were adjudicated as group 3 as their primary diagnosis. And then we had others that had group 3 risk factors where group 3 pulmonary hypertension could be a secondary diagnosis. So one of the things is that sleep apnea was highly prevalent. And I don't think we know enough about the influence of sleep-disordered breathing and intermittent hypoxia in the context of pulmonary hypertension and parenchymal disease. And we had 66 patients with COPD, and we had a total of 90 patients with interstitial lung disease in our cohort where group 3 was the primary diagnosis. These patients were older than the typical PAH patient in our cohort, and the sex distribution was equal between males and females. They were also more likely to have a more advanced functional class, and this was similar to the comparator, so interstitial lung disease without pulmonary hypertension. And so the decrease in their functional class might not be solely attributable to pulmonary hypertension, but due to their underlying pulmonary disease. They tended to have the worst 6-minute walk test. Group 2 and 3 had the worst 6-minute walk test, and their walk was worse than their comparator, so worse than COPD without pulmonary hypertension or ILD and without pulmonary hypertension. And they had the worst diffusion. But diffusion was low for all the groups. So diffusion is not a great discriminatory value. We know that it may indicate pulmonary vascular disease, but that's about as far as we can get. In regards to hemodynamics, our cohort, but their outcomes were more severe. So the right atrial volume index seemed to predict better than right ventricular dilatation those that may have pulmonary hypertension, and this was across the groups, but included group 3. And there was a lot of nocturnal desaturation. And there was a significant amount of apnea, hypopnea across the groups. But the groups that had the worst apnea, hypopnea index was group 2. And so the oxygen desaturation, the nocturnal desaturation, both in group 1 and group 3, could not be fully explained by sleep-disordered breathing. I think what's interesting, we were just having a discussion about this at lunch today, is how it is so difficult to have what we would consider a pure pulmonary arterial hypertension group. That if we look at our patient population, if we look at our patients that are included in studies, often they have a little bit of this or a little bit of that. And so in our patients who who were adjudicated to be pure group 1 patients, 10% had some evidence of emphysema. 17% had some evidence of interstitial lung disease. And what's particularly interesting is that 50% of our group 1 patients had evidence of ground glass opacities. And if you looked at who are those patients, those are the patients that were on parenteral prostanoids. In group 3, as we would expect, they all had different types of parenchymal abnormalities and which were more prevalent than in the other groups. So, mixed etiology is common, and we've gotten away from the terminology out of proportion. When we have a group 3 patient, we say, is this severe pulmonary hypertension or non-severe pulmonary hypertension as we're thinking about our treatment decisions? If you look at patients that are in group 3 as a secondary, this is the primary group, this is the secondary group. If you look at patients in group 3, it is the most likely secondary diagnosis. And if you look at patients who are group 3, group 1, group 2 are the most common secondary diagnoses. And so one of the messages is that group 2 disease in particular is highly prevalent in group 3 disease, which is another reason it might be difficult to treat these patients. If you look at the patients specifically that are mixed group 1 and group 3, sleep apnea is the most prevalent secondary diagnosis with kind of equal prevalence of COPD and interstitial lung disease, and they had a lot of other comorbidities, hypertension, diabetes, thyroid disease, were more likely to have connective tissue disease, kind of a mid-level BMI, lower pulmonary severity, and echo tends to underestimate pulmonary hypertension. But both should be suspected with a profound reduction in diffusion. On CT, the PA to aorta ratio is predictive of pH somewhat in COPD, and there seems to be a correlation between air wall thickness and pH. In ILD, there is the PA to aorta ratio is somewhat inconclusive. COPD pH tends to be more slowly progressive, and the poor prognosis is only if there's very severe pH. Where in PH-ILD, it's more rapidly progressive, and any pH is bad. In treatment, in COPD, we yet to have any treatments. In PH-ILD, inhaled treprostinil was recently approved. Both could get lung transplant in the appropriate setting. And there's a vast difference in survival curves between COPD and ILD. ILD and PH is a much worse thing. And here you can see Kaplan-Meier curves. This is ILD, where you can see this is without pH, and this is borderline, moderate, and severe pH. They all overlap and are bad. Where this is our COPD cohort, and the brown line is the severe pulmonary hypertension. The rest, until you get to severe pulmonary hypertension, maybe is not quite as scary. So with that, I'd like to summarize that the pathobiology of group 3 involves a complex interplay between vasculocentric, parenchymal, and comorbid phenotypes. Differentiating between group 1 pH and group 3 pH can be challenging and requires consideration of hemodynamics in the context of the burden of lung disease. And pH in COPD and ILD is heterogeneous with differing pathogenic mechanisms, clinical presentations, and outcomes. And survival is poor, but there is different effects on the outcome in COPD and ILD. And I'm just gonna leave you with, we have that one box that says COPD and ILD and, altitude, and and whatnot. But I think our box may need to be a little bit expanded because there are a whole lot of different types of lung disease, and in the gray, I've added sarcoidosis and pulmonary histiocytosis, which are more usually seen in group 5. But I think, you know, there's a lot of heterogeneity, and as we kind of understand the nuances of these different types of lung disease, we'll have a better shot of making progress in this group. And with that, I'd like to thank you for your attention.
Thank you, Dr. Highland. If you can join us here on the stage, please. Christine, can you join us here? Thank you. It's now my great pleasure to introduce the next speaker, Dr. Luke Howard, which is introduced in the morning. He's a pulmonologist from Hammersmith Hospital, Imperial College. He's going to talk about PH in ILD, impact on survival, and importance of screening. Luke.
Thank you very much. And you know what I said about the great thing about being invited back again is this one happened really fast. You get me again, you lucky people. So you've had lunch, you're 20 minutes in, the eyelids are feeling heavy. And so my job now for the next 20 minutes is to get you excited about PH and ILD and survival and screening. So I did look at this talk and I thought, wow, this is going to be tricky, but it was made a lot easier by my neighbor on the plane over from London, which is Steve Nathan, who we had some great discussions. So I actually really enjoyed preparing this talk, and I think if you enjoy preparing a talk, hopefully it'll be interesting to deliver and to receive. So here are my disclosures. Now, pulmonary hypertension definitions. First of all, if we're going to talk about mortality in PH-ILD, we need to know what PH means, right? So for pulmonary hypertension in general, it's nice and simple, or should I say nice and simple, as the latest ones were derived in Nice. So you can see from 2015 to 2022, there's been a change in the threshold from 25 and above to 21 and above, or more than 20, and there's been a drop in the PVR, although that's not in the left-hand figure. It's been from 3 down to 2 Wood units. And the reason for that is that because up to 20 and up to 2 Wood units is considered normal. So kind of nice and easy, right? You know what's normal, you know what's abnormal. Not so with pulmonary hypertension lung disease. Okay, so this was the 2015 definition. You can see a pressure of less than 25, no pH, that's simple. Above 25, there's pH, and then we have to define what severe pH means. And so in that situation, it was a pressure of 35 or more, or 25 with a low cardiac index of under 2.5. Then in 2019, at the World Symposium, which is held in Nice, it was adapted slightly, and this with a preview to the 2022 guidelines, but as you'll see, that didn't quite make it through. And we now have chronic lung disease without pH, so a pressure of less than 21 and a PVR of less than 3. You can have a pressure of 21 to 24, but a PVR of less than 3, because you could have high cardiac output, for example. Then chronic lung disease with pH is a pressure of 21 to 24 with a high PVR, or a pressure above 25. And then finally, chronic lung disease with severe pH. Again, the same as before, pressure of 35 or more, or 25 with a cardiac index, this time less than 2, not 2.5. So some slight changes in there in the 2019 definition. So here in the next 2 slides is what illustrates the problem. It's an absolute mess. It's a horror show, okay? So all of these different studies showing that pulmonary hypertension portends a poor prognosis in lung disease. You can see, what have we got? We've got an echo definition at the top. Then we've got a right heart cath definition of 25 or more. Then we have a cath definition of a mean PAP of more than 17. Then we have an echo definition of 40. And then we have an echo definition of 35 to 49 with mild to moderate, and then severe PH with an SPAP of more than 50. So all the studies say, yeah, survival is worse if you have pH, but all the definitions of pH are different because you have invasive and non-invasive measurements. I mean, it goes on, okay? You can see there's an issue here. We've now got MPAT more than 20, high PVR, then the new definition here in the middle, and then we have an echo definition, and then finally we have a pure PVR definition. So it's a mess. Yes, we know it causes worse prognosis, and we heard this just right now in the preceding talk. So why is this problem? Why is there this difference? So in PAH, the hemodynamics are simple. You're either abnormal or you're normal. In PH lung, why is there a problem? There is a problem because we expect some degree of pulmonary hypertension with lung disease. That's what we expect. So when does it become abnormal? So we've got these nice plots, and there's various different ways of looking at things, I think this it's a very recent publication from the PVRI workstream, effectively saying that in one direction you have worsening pH severity, that's on the y-axis, and in the other direction you have worsening ILD severity on the x-axis. But actually your patient can be anywhere in those plots. You can have somebody with mild lung disease and severe pH. You can have somebody with severe ILD and mild pH. You can be anywhere. So how to define what level is pH is difficult. So how do we define it? Well, the simplest way of doing it is to say, at what point is it relevant? It's when it causes excess mortality. Okay, so that's one way of doing it. But there's more to it than that. If you say to a patient, well, I'll define when you've got pulmonary hypertension by when you die, I mean, okay, it's a silly example, that's not the relevance. There's a whole burden of disease that the patients experience as pH becomes relevant in the process. So we go from increasing shortness of breath and cough to fatigue, dizziness, syncope, and then right ventricular failure. So, but we're just saying pH, we'll define that by when there's an excess mortality. So how else could we do it? We could say pH is when you start to get right heart symptoms. That's going to be difficult. That could be done by hemodynamics. Or when you think that something has started to develop. So that might be in the phenotyping. So suddenly your ILD looks stable on CT, but suddenly your diffusion starts to drop, your oxygenation starts to change. That's when we, in our minds, as clinicians, think there's a pulmonary vasculopathy that's kicking in. But again, difficult to define. So when it causes excess mortality seems to be the gold standard way of doing it. So the final row that I didn't show you in that massive table is the most recent studies that have effectively laid down the current standard of PVR of more than 5 Wood units being associated with worse survival. Let's dig into that a little bit. This came from the Compera registry. And so, yeah, that's just completing that slide for you. We'll dig into, oh, no. I have something interesting to show you before then. So you'll notice the reference on the bottom of this. It's Howard and Nathan, BA Flight 0263, London Heathrow to Riyadh Airport on the 14th of February. So this is when this was conceived. And what we were discussing was the fact that you could take a whole cohort and do a Kaplan-Meier curve. And you can split the patients 50-50, okay? And what will happen is you will get this situation. And you'll get a cutoff of 5 Wood units. So you can say to your patient, this is the cutoff. So they say, oh, that's fantastic news, doctor. My PVR is 4.9 Wood units, so I'm going to be okay, right? No. So have you got a good prognosis if you split something down the middle? That's with all the old 6-minute walk data, 380 meters. Do you remember that? It's just that's the median, okay? So no, it just means that it's better than bad. So you have a really bad prognosis and better than bad. So what else can you do? You can have multiple strata so that you can get the good prognosis closer to good, and then you have worsening prognoses. That's one potential option. And that's what we tend to do with PAH, which is cleaner. Or what you can do is say, this is good, and this is a number of patients that we have, and this is bad, but this group is very broad. But what we're trying to do is define the patients who have a good prognosis that we don't need to worry about so much or treat. And effectively, I think this is where we're slightly going. So this is the comparer data, and what you can see top left is a plot. On the x-axis, you've got the PVR and Wood units going from 4, 5, 6, 7, 8 up to 14. And on the y-axis, as I understand it, you have the probability that this cutoff is relevant in terms of survival. Now you see it starts to kick in at 4 Wood units at a p-value of 0.04 something. And then at 5 Wood units, there's a sudden drop in the p-value down to 0.03. So that's why they chose a PVR of 5 Wood units to define pulmonary hypertension. And interestingly, if you look at the bottom right, you can see the 2019 definition of severe PH with the pressure and the cardiac index. Absolutely no differentiation, which is quite surprising. Okay, I want you to look closely because this bit took me a while to sort out. Oh, it's nice, isn't it? Right, so what's interesting is on the right, you've got 5 Wood units. And on the left, you've actually got the best discrimination, which is 8 Wood units. And then you draw some lines across at 50% survival. Not a huge deal of difference, whether it's 5, whether it's 8. So I find that kind of interesting, but you can see why 8 Wood units is perhaps the most statistically significant because of the way the lines separate out. So anyway, what we have is less than 5 Wood units means this is as good a prognosis as you're going to get, and if it's more than 5, then it's bad. And so we just now define it with this straight line across here. At least it's simple, okay? But is it right? So here's some data from the INCREASE trial with inhaled treprostinil in PH-ILD. And what they showed here, this is not survival, but they showed the benefit of therapy, and they looked at a cut point of 4 Wood units. Remember I said it just came in at 0.049 or something? 4 Wood units, and what you can see on here is that patients with a PVR of more than 4 Wood units gained a benefit from therapy. What does that mean? That means that there is potentially a pulmonary vasculopathy worth treating. So maybe 4 Wood units. It's all getting a little bit arbitrary, isn't it? But I just wonder if that's an argument for it being 4. And maybe, look, Steve is the guru on this, and maybe we can chat about that afterwards. So now, second part of the talk, should we screen? So what I've done is I've taken a UK national screening definition, crossed it out and adapted it for pulmonary hypertension. So screening would be a process of identifying patients with interstitial lung disease who may be at increased risk of PH. They can be offered information, further testing, and appropriate treatment to reduce their risk and/or any complications arising from it. So that would be the screening process and why you would do it. So let's look at the Wilson and Jungner criteria for screening. So first of all, you have to know the disease. The condition should be important. Tick. There must be a recognizable latent or early symptomatic stage. Tick. The natural course of the condition, including development from latent to declared disease, should be adequately understood. Maybe by Steve, not so much by me, or Kristen. I meant Kristen understands it. Sorry, I put you in the wrong bracket there, Kristen. Knowledge of the test. Okay, there's a suitable test or examination. Yeah, we have those. The test is acceptable to the population. Depends what you're talking about here. Right heart cath, maybe. Case finding should be continuous. In other words, you don't just do it once. It's a continuous process. So I think we're happy that this is that screening for PH-ILD potentially meets these definitions. So our definition is a PVR of more than 5 Wood units. Does that mean we should catheterize everybody? Well, no, of course not. We have to have some stages in between. So if we now look at the test, it should be simple, safe, precise, validated. The distribution of the test values should be known, and there should be a suitable cutoff. It should be acceptable, and there should be an agreed policy on further diagnostic intervention of individuals with a positive test result and on the choices available to those individuals. So let's see. Right, now, you can start by asking a friend or asking an expert. And this was, thanks, Steve, for pointing this one out, because I missed this, study in my search. This was a Delphi study. So you ask lots and lots of questions and get people to rate their scores. And they ask multiple experts these various questions. Who would benefit? You know, what kind of ILD? What kind of disease characteristics? What were the clinical features that would make you think of pH and doing a cath? What non-invasive features would you look for in CT or SATs or BNP, lung function or walk distance, that would make you think of doing maybe an echo first and then a cath? What non-invasive tests should be done, and how would you assess that your ILD is stable, but you've got progressive clinical deterioration? So they came up with this very simple thing that you can do in 5 seconds in front of your patient. You know, there's risk factors, so history of PE or heart failure, clinical features such as syncope, these various sounds that you'll pick up on auscultation of the chest. Then you're going to look at your tests and you'll remember that, you know, you're looking for a DLCO decline of 15%, an FVC DLC more than 1. Are you getting lost now? I'm getting lost. But these are the things that experts will be processing at 1,000,000 miles an hour in their heads when they're looking at their patients and thinking, does my patient have pulmonary hypertension? They'll look at the CT scan, the BNP. And then they will have either a high suspicion or a low suspicion or no suspicion. Now, if you have a high suspicion or a low suspicion, you do an echo. Okay, you might think that's strange. Hold on a minute, it's fine, it's not a typo. And on the echocardiogram, you then integrate your clinical probability of pH, clinical probability of pH with the echo probability. So, for example, if you have a low clinical suspicion and of pH and a low echo suspicion, no right heart cath. But if you're somewhere in the middle and you have a high clinical suspicion of pH and an intermediate probability on echo, you do a cath. Okay, so that's kind of how screening works, but it's quite complicated. So one of the questions is, you know, can you use a scoring system? If you want to use that system, you can print this out and stick it up on your clinic room wall and look at it every time you're thinking about a patient. But what about a scoring system? So this is in press. I wouldn't have picked it up, again, had I not been sitting next to Steve on the plane. This is called the Ford calculator. So it will be driving into your clinic anytime soon. And this is a scoring system based on 4 parameters only. So FVC-DLC ratio, oxygenation, race, and distance walked on a 6-minute walk test. And you can add these up and get your scoring system. It gives you an area under the curve for predicting pulmonary hypertension of 0.75. This was both derived and then validated in a separate population, so it gets a nice little star for that. And looking at various cutoffs, at the bottom you can see a score of 53 or more, 21 or more is optimal via the Uden's index and gives you a sensitivity of 72% and a specificity of 69%. I don't quite understand this CART business, but it doesn't look very good in terms of sensitivity, so the moral of the story is don't put the cart before the Ford. You have to be a native speaker to understand that. I can see the native speakers giggling, but if you want to understand that joke, come and speak to me later. It's pretty poor. Now, there is another detection tool. Now, this was derived but not validated. It's slightly simpler in terms of the scoring, and you can see the features there: walk, physical exam, DLCO, oxygen, BNP, syncope, PA enlargement, and CTD or sarcoid. And then you've got 3 nice levels of cutoff: 3, 4 to 5, and greater than 6. Now, if your score is more than 6 or more, this gives you a good area under the curve of 0.92 for predicting pulmonary hypertension. Now, this got me thinking, why are we so het up on defining pH just by a number, a PVR? Because, in fact, these scores are telling you about a pH phenotype. Do we have to go that extra step? Maybe a score is what you need to define somebody who has a poor prognosis and who needs and may benefit from treatment. Yes, you need a cath to confirm their precapillary, but if you have a bad score, it tells me that you have that phenotype, that pH-ILD phenotype. So in this study, they actually did look at whether the score predicted mortality, and yes, it does. So I wonder, Should we move away from hemodynamics as defining whether you get treatment or not, and maybe look at a scoring system as long as you have a diagnosis of precapillary pH? So I think that's up for debate. Is PVR so crucial, or should we be looking to phenotype our patients this way? So the final bit of screening is you have to have a treatment. You have to have an accepted treatment for patients with a recognized disease. The facilities have to be there to diagnose and treat, and you have to have an agreed policy on who is going to get treatment. And you have to consider the costs of looking for the cases and then treating them, and looking at the costs within your whole medical setup. So in 2021, Steve and is it Jürgen Behr, is that his first name, Jürgen, wrote this opinion piece. Increase had been published, but treprostinil wasn't licensed at that stage, and they wrote some pros and cons here on the benefits and risks of screening. So you can see in the cons, no specific therapeutic consequences. That's changed now. So we maybe have more pros than cons. But does the therapy really work? And very conveniently, at this point, I can hand over to Steve and Olivier to battle it out. I have to say, when I discussed this debate with the two, they had facial expressions that look pretty similar to what you can see on the screen. So Olivier is looking a little bit, I'm not sure why I have to have this debate. Anyway, so I'm really looking forward to this, and I hope I've set the scene for you both. Thank you very much.
Wow, that was powerful. Both of you really set the scene, and I hope we don't disappoint. It's indeed a great pleasure and an honor to be invited by the organizers to this meeting, which has been outstanding. The quality of the talks has been exceptional, and I'm just very happy, and it's a pleasure for me to be here. So here we go. I'm the pro, time to treat all. And I said to Olivia when we met at PVRI, you've won the debate already, because whenever you have all in the title, I'm going to lose, because all you have to prove is that there's one case that you don't have to treat, and you've won the debate. But maybe I can convince everyone that at least to consider therapy in all. And Luke, you're doing such a great job, you should have just carried on with my slides. These are my disclosures, but just to go back to our little trip on the airplane, get away from our disclosures, it was a lot of fun talking, and I was very happy afterwards to see the slides you put together. And then as I was sitting in the audience, I was thinking maybe we can get this published somewhere. And I thought with the British Airways in-flight journal, maybe we can get published there. But then I thought, what's the impact factor? And you don't want an impact factor with any in-flight journal, right? That's another pun, sorry. Okay. Anyway, so what we know, and what the prior speakers have alluded to, is that the prevalence of pulmonary hypertension complicating interstitial lung disease can be quite high. And it really depends when during the course of the disease you look for it. If you look at that last number, 86%, it seems like it's almost invariable that everyone at some point, if they don't die of something else, will get pulmonary hypertension. This is a survival plot of patients with and without pulmonary hypertension by one of the older definitions, MPAP greater than 25. And you can see the histogram distribution of the PA pressures from this particular study, where 50% of those who had pulmonary hypertension sat between 25 and 30, to the point that even mild pulmonary hypertension portends a much worse outcome. Some of these slides you might have seen already from amongst all the different groups. Group 3 has the worst prognosis, and then if you look amongst the Group 3 patients, ILD and IPF have the worst prognosis, which is, and I think Luke got to this very nicely about our cut points of PVR. Does it really make a difference if you have a terrible prognosis versus a really terrible prognosis? And the answer would be no. This is from the Spanish pH registry, where you can see patients with no pH, blue at the top, and then borderline, mild to moderate, and severe. And I think a distinctive point to be made around this is if you look at the survival, my lines aren't coming in, but if you look at the survival, even of those with borderline pulmonary hypertension, it's pretty bad. And so what we need to get away from, and Luke alluded to this as well, is that mild pH does not mean that you have mild disease. Mild pH means that you have severe disease, because anyone with a prognosis like that has severe disease. So we need to divorce the two. Oh, there we go. I think my clicker's become unresponsive. Luke, you put the clicker to sleep somehow. I'm kidding, it was very exciting, very exciting. Let's go back 20, 30 years, actually more, to the early 90s, when we used to talk about PPH, primary pulmonary hypertension. I think there's some of us in the audience who are old enough to remember making the transition from PPH to IPH. This was in the days of PPH, and this was the NIH registry when we had no treatments at that time. And the prognosis was rather dismal, 2.7 years untreated. Now, if you put the two next to one another, let's compare prognoses. And you can see that what we're talking about is a prognosis of 2.7 years versus less than 18 months. So PH-ILD has a worse prognosis than IPAH untreated. The point to be made with regards to therapy is that the worse the prognosis, the lower our threshold should be to adopt any therapy that might be available. Not only does it have an impact on mortality, but there's an impact on functional ability, as seen by walk distance, oxygenation, healthcare resource utilization, hospitalization. So there's a tremendous ripple effect that mortality doesn't get to that can be seen in these patients before they succumb. Everyone's familiar with all the drugs that have been approved for group 1 pulmonary arterial hypertension, just shown over here. And the more drugs that have been approved for group 1 PAH, the more tempting it becomes to look at these drugs in other groups, specifically in group 3 pulmonary hypertension in this case. And the concept is rather simple. If patients have a breathing limitation and they have both lung disease, ILD, and pulmonary hypertension, what is causing their breathing limitation? Is it the pH or is it the ILD? And if it's the pH, can you treat them with one of these vasoactive therapies to the point that their parenchymal lung disease then becomes the limiting factor? And you could interpose mortality with breathing limitation as well. Can you improve their prognosis by treating their pulmonary hypertension? There'd be many small case series, retrospective looks at treating pH due to ILD. These are the only randomized controlled studies in PH-ILD, and they're color-coded. Orange is neutral, red is bad, and green is good. And you can see at the bottom we have the increased study. So very few studies, a suggestion of harm even with the RISE-IP study, which was riociguat, but as I'll get into, the increased study was unequivocally positive. So why have we had these equivocal studies, harmful studies, and helpful studies? How do we explain this? And it's very hard threading the needle for a successful clinical trial design. I'm going to try and thread the needle here. First of all, you need a drug that works and is well tolerated. You need to come up with the right dose, frequency of administration, and route of administration. You need the right patient phenotype. You need the right endpoint. The study needs to be recruitable and retainable. It's one thing getting the patients in, you've got to keep them in the study. And then you have to have the right duration. And if you mess up on any of these branches, you can have a negative study. And you'll notice that if you thread the needle, you have a big W there, you have a win. And so this is probably why when you have complicating ILD or even COPD and pulmonary hypertension, threading that needle gets even more difficult. So let's move on to the increased study. This was published in the New England Journal in early 2021, inhaled treprostinil in pH due to ILD, the largest study to date of group 3 pulmonary hypertension. It was a RCT where patients were equally randomized to inhaled treprostinil 4 times a day versus placebo, 16 weeks. The primary endpoint was the 6-minute walk distance with multiple secondary endpoints. And these are the patients' demographics shown over here. So a typical mix of ILD patients. They were a pretty sick group of patients. About 70% of them were on supplemental oxygen, to the point when you screen, you don't need to be on supplemental oxygen and you can still have pulmonary hypertension. So don't necessarily wait for them to become oxygen dependent. And this was the result as published in the NEJM, with a 31.12 meter difference, placebo-corrected, in the 6-minute walk distance at 16 weeks. Most of this notably driven by improvement in the treatment arm And in the context of fibrotic lung disease, how often can we say to ourselves or to our patients, well, you might improve in actual fact. If you look at the antifibrotics, they delay progression of disease, but they don't improve. And that was my response. In terms of the most important secondary endpoint, it was time to clinical worsening, and the study met this as well. This was a composite of hospitalization due to cardiopulmonary reason, categorical decrease in the walk distance, all-cause mortality or lung transplantation, and it squeaked by with a p-value of 0.04. Nonetheless, it was statistically significant. I think it's great when you hit on your primary, even better when you hit on your most important secondary, but the cherry on the top was a biomarker evidence of efficacy through the NT-proBNP, which went up in the placebo arm and went down in the treatment arm, so kind of underscoring the clinical benefits that we saw from the study. And Luke showed this already. This was in the supplement, but if you go back to the group whose PVR was less than 4 over here somewhere, you can see that there's no apparent difference in terms of the outcome as measured by the 6-minute walk distance. And Olivia, I don't know if you're going to show this as part of your case in terms of why we shouldn't treat, or maybe there's some patients who shouldn't be treated. But there is a paper that's pending, it's in submission, or it's with revisions to BMC Pulmonary, looking at patients with PVRs less than 4, and we can certainly see benefit here in other measures of disease in terms of the NT-proBNP, and which I think underscores that even early on, these patients warrant therapy, even if you didn't show a difference in the walk distance at 16 weeks. This is also from the same paper, looking at exacerbations for those patients with a PVR less than 4. Certainly, this forest plot has wide confidence intervals, but the point estimate is well below 1 for exacerbations, as well as for clinical worsening. So not everything resides within the 6-minute walk test. There are other things and other benefits potentially that patients can get from this particular agent. So in March of 2021, we were fortunate in the US that inhaled treprostinil was approved for PH due to ILD or associated with ILD. And I think this has really represented a paradigm shift in how we look at this disease and how we treat these patients, certainly in the US. I think from my personal frustration standpoint is the lack of availability of this agent in other places. As far as I know to date, I think it's approved in Argentina. I heard it was approved in Israel. I'm not sure if it's approved anywhere else. But I think when we're dealing with a patient group who has such a poor prognosis, as I mentioned, why not offer them something that potentially can make them feel better and give them some hope? So how does INCREASE stack up to all the PAH medications that are approved? And I'll go back 20 plus years to look when we still did studies of single agents versus placebo. You can see them all there: bosentan, ambrisentan, sildenafil, tadalafil, riociguat, inhaled treprostinil. And if you look at the number of patients in these studies, the INCREASE study was right in the mix in terms of the number of patients enrolled. It was right in the mix in terms of the duration of the study, had the same primary endpoint, and the result was pretty much right in the mix with what we saw with Group 1 PAH agents that were all approved and given high levels of recommendation for use subsequent to that as well. And in addition, hitting all, a bunch of different secondary endpoints in terms of clinical worsening and the NT-proBNP. So I think that this study is at least equivalent to what we saw with some of the monotherapy trials in PAH. I think we are 20 years behind the field of PAH when we talk about PH-ILD, in that we only have one drug at this time to offer these patients that has been shown to work definitively. There have been a bunch of post-hoc analyses of the INCREASE study which have underscored its benefit. This was one that was published in CHEST, I believe it was last year, where we looked at clinical worsening and clinical improvement based on dose. And you can see a nice dose effect here, where as you get up more than 9 breaths 4 times a day, you have more patients who have clinical improvement and at the same time have less clinical worsening. This is another one that was published at the EPUB in the Annals of ATS, looking at the win ratio. The win ratio has gained a lot of popularity in terms of how we should evaluate composite endpoints. The traditional composite endpoints treat all the endpoints the same. So if you hit the 6-minute walk component first and then you die later, the death is encountered, and certainly mortality is much more important than a categorical change in the 6-minute walk test. So what the win ratio does, it establishes a hierarchy of events in terms of most important to least important. So the most important event for patients would be mortality, and you can see that inhaled treprostinil beat out placebo over the 16 weeks in that category. Then you take away the patients who died, and you look at the next most important event, which is cardiopulmonary hospitalization. And inhaled treprostinil once again wins out over placebo there. The third most important event, arguably, is the 6-minute walk distance, and there's a win there. And the advantage of using the win ratio is that as your last event in terms of the hierarchy, you can throw in clinical improvement. So how many patients who didn't have clinical worsening actually improved? And you can see that inhaled treprostinil wins there. So right across the board, inhaled treprostinil wins out over placebo over the course of 16 weeks. This is a publication that's now an EPUB in thorax looking at potential mortality based on some fancy statistical modeling that has been validated in the oncology literature, suggesting that inhaled treprostinil given longer than 16 weeks will result in a mortality benefit. Now you could argue, well, this is just statistical modeling, but this has been well validated in the oncology literature. And I'll go back to when our antifibrotic pirfenidone was first approved, and we had no idea about mortality. And we did similar modeling of the pirfenidone data set. And what we showed with that, the clicker's gone to sleep. Ah, there we go. What we showed with that, I'm not sure what I should be pointing this at, was a 2.5-year difference in survival based on the statistical modeling. And if you look at all the registries that are out there now, where does it sit? It's about 2.5 years that has subsequently been validated with ongoing use of pirfenidone. So I think this lends a certain amount of, or more credibility to the modeling that I just showed you with inhaled treprostinil. Whoops, too quick. There's also data to suggest that sildenafil might have a mortality benefit. This was a very nice study, a retrospective study, but they used very rigorous techniques, Bayesian retrospective observational cohort. The patients were matched very equally, and this also showed a difference in survival, but it wasn't a true RCT. Now, as everyone knows, the ESC and ERS came out with their guidelines 2 years ago in 2022, and what was said at that time, before I show you what they said about treating group 3 pulmonary hypertension, I'll just go through the various categories in terms of how they grade it: class 1, class 2, class 2A, class 2B, and class 3, and then levels of evidence, level of evidence A, but I'll focus on B because that's where the increased study sits, data derived from a single randomized clinical trial or large non-randomized study. And what they decided over here was basically to give it a 2B. There we go, 2B, and 2B for sildenafil as well. And just as a reminder, what does 2B mean? Where should I be pointing this thing? Over there. There we go. 2B is may be considered for use. Usefulness, efficacy is less well established by evidence or opinion. Well, I'll argue against it. I think it's at least a 2A. Weight of evidence and opinion is in favor of usefulness and efficacy and should be considered rather than may be considered. And I think you can even make a case for it being a class 1 recommendation, is recommended. Doesn't mean you have to use it in every case, but what does class 1 mean? Evidence and or general agreement. So I think there's certainly the evidence. I think there's agreement, and in actual fact, living in the Washington, D.C. area, I do take care of a general who works at the Pentagon. I put him on inhaled treprostinil, and he's in agreement that it works. So there is general agreement that it works. Half-true story. All right, so what would I recommend as a suggested management approach? This is our most recent iteration, or actually I need to change this. This is our other iteration of what pulmonary hypertension is. But this wasn't the INCREASE study. The INCREASE study was started when we had the prior to 2019 definition, so you had to have an MPAP of 25 or more with a PVR of 3 or more. So for these patients, we still need to do the appropriate studies. But once you get to an MPAP of 25 or more and PVR of 3 or more, we have the evidence there that inhaled treprostinil works and should be used if available. Of course, we need to before we do that, we need to make sure we address any comorbidities that can be contributory to this, and consider referral to an ILD or PH program. Next step, transplant referral. Some of these patients might be transplant candidates, and you can do the two concomitantly. You can put them on treatment and refer them for transplant, because invariably they're going to probably need a transplant. If anything, inhaled treprostinil might enable them to stay in that window to be a transplant candidate for longer before an organ becomes available. If they're intolerant or it's unavailable, you can consider a trial of sildenafil based on the existing evidence, but there's no RCT to show that it works. If they have severe pulmonary hypertension, refer to a pulmonary hypertension program. Now you'll note what I put here, severe pH should be determined by the pH specialist. Personally, I really don't like the definition of PVR greater than 5. What if it's 4.9 versus 5.1? It's a continuum, and let the pH specialist put it in context and decide if it's severe enough to warrant therapy. And in some cases, and we've had this experience ourselves, we put them on prostanoids, and anecdotally, I think that intravenous and sometimes subcutaneous prostanoid therapy can work in these patients. 2 drugs contraindicated, important to know, ambrisentan and riociguat, based on studies that I didn't show you. So time to treat all, I say time to consider treatment in all. This is a gentleman trying to change his tire under 2 wooden things. This is not a good idea. These are gentlemen trying to get out of the sun and sitting under this big tractor. Also not a good idea. Waiting to treat PH and ILD, also not a good idea. So I'll stop there and happy to hand it over to Olivier. Thank you all very much.
Thank you. Thank you so much, Steve, for this very, very comprehensive review and for setting the scene for my rebuttal. Thank you so much. So I will use many of the slides you have seen, but with a different interpretation. So these are my disclosures. So first of all, management of PH-ILD needs a holistic approach, and treatment of the pulmonary vascular disease is one of those approaches, but we don't have to forget ILD with oxygen treatment, management of comorbidities, rehabilitation, management of dyspnea, and ultimately lung transplantation, of course. But it's just one of the part of this approach. And as you know, until recently, the treatment of PH in ILD was very, very disappointing. This is a list of the different trials with negative results using either endothelin receptor antagonist or PDE5 inhibitors or also riociguat. As you can see, we have a lot of the primary endpoint was not met in all of those studies. And that's why in the guidelines in 2015, there's a clear statement of the use of drug approved for PH is not recommended in patients with PH due to lung disease, 3C. Just some example of what I showed in the table. Bosentan in PH associated with interstitial lung disease, is ineffective. It was a randomized controlled trials, and the primary endpoint was a change in PVR of more than 20%. And as you can see, there was no difference between placebo and bosentan. And if you look at the secondary endpoint, we did not have any significant change. Another endothelin receptor antagonist, ambrisentan. We know that ambrisentan is harmful in idiopathic pulmonary fibrosis because we observed in this trial that we had more disease progression, more hospitalization in patients receiving ambrisentan as compared to others, to placebo. And in this trial, we had a subgroup of patients with pulmonary hypertension, and when this subgroup of patients was analyzed separately, there was no efficacy demonstrated in this subgroup, in this subset of patients. So ambrisentan in IPF and PH is ineffective. Finally, riociguat. Riociguat is not only ineffective, but it is also dangerous. And it is a RISE-IP study, the randomized placebo-controlled phase 2 trial with riociguat. It was early terminated due to an increase in worsening of ILD and also in mortality, and without any signal of efficacy in the riociguat group. So, next step, my distinguished opponent tried hard chasing a unicorn. So, he published 2 trials, one on inhaled nitric oxide. It was a short-term trial showing the superiority of inhaled nitric oxide to placebo, and the primary endpoint was actigraphy. And you know by heart this famous trial of inhaled treprostinil in pulmonary hypertension due to interstitial lung disease, and I will come back on this. Inhaled treprostinil in PH-ILD improved the primary endpoint. It's true, but the devil's in the details. If you look at this, okay, there is a marked improvement in the primary endpoint, change in 6-minute walk distance by more than 30 meters. It is clearly a very significant improvement on inhaled treprostinil as compared to placebo. However, if you look at the details about the 462 patients screened, only 326 were randomized, and finally 258 completed the trial. So we had a 30% screen failure, 21% dropout rate. It was similar in both groups, and only finally 56% of patients exposed. We also know that there was a nice reduction in NT-proBNP, as it was shown in the previous presentation. Also a reduction in the clinical worsening, but no effect on other secondary endpoint. And finally, the improvement was most evident in patients with IPF. If we look at the time to clinical worsening, it was presumably improved. It's true, but again, the devil's in the details. If you look at the component of the time to clinical worsening, you see that this secondary endpoint was driven by 6-minute walk distance, which was the primary endpoint. It's quite logical if you include the primary endpoint in the secondary endpoint, that secondary endpoint may be a positive endpoint. Does treprostinil work in all patients with PH-ILD? I remind you the title of this debate, all patients. Look at the etiology of the ILD in the INCREASE study. Maybe it works in IPF and in connective tissue disease. That is true. It is less sure in combined pulmonary fibrosis and emphysema, CPFE. Less evident when you look at this forest plot. Are we so surprised by the effect of inhaled treprostinil in CTD with PH-ILD? We know that CTD patients with PH could fit into any of the first 4 groups, group 1, 2, 3, sometimes 4. Even in CTD patients with severe ILD, a prominent vascular component cannot be excluded, and we know that it exists. And this may perhaps explain why a PH drug works in CTD with PH-ILD. Is it effective in all PH patients with ILD? Look at this patient severity. Look at this PVR category, less than 4, more than 4. It is very clear in this forest plot that the drug is effective in the most severe patients, more than 4 wood units for PVR. It is not at all effective in patients with less severe PH, with PVR or less than 4. Let's move now to the open label extension of the INCREASE trial. What did we observe? It was an unprecedented discontinuation rate. 70% discontinuation in the open label extension from 243 patients enrolled in the open label extension. And at the end, only 70 patients received treprostinil in the open label, including, we had 172 patients who discontinued, including 56 patients who died. It's a lot. What about the response to inhaled treprostinil in the patients on background, who previously received the placebo? What we observe is that the patients initially on inhaled treprostinil, they stabilize during the open label extension. It is quite obvious here. What happened in the ex-placebo? It is the ex-placebo during the double-blind phase. There is no improvement, of course. It was expected. But what happened in the open-label extension? I remind you that those patients receive inhaled treprostinil after the double-blind phase, and they do not improve at all. There is no change in 6-minute walk distance in those patients. What about the time to first event? When we look at the open label extension, and we look at the double-blind phase here, and then the open label extension. We have a trend, but it was not significant in favor of inhaled treprostinil. The hazard ratio was 0.8. The p-value was 0.11. And we have a remarkable superimposition of the two curves here. And after, there is a separation, but at the end, it's almost the same. What about survival? And this is the paper that Steve mentioned, which is published online in Thorax. I also got it and read it. Look at there is a lot of speculation in this study. Look, in the double-blind phase of the study, we did not observe any difference into the two groups. Within the first 16 weeks of the study, we do not have any differences. It's 12 deaths against 10 deaths. What happened in the open label? In the open label, it seems that we observed something, but it was no significant. In intention to treat analysis, we have no difference in between patients receiving inhaled treprostinil from the beginning or the patients who were crossover from placebo to inhaled treprostinil. And the p-value was 0.12. That's why they decided to use some quite complicated methods, and for me it's a masterclass of speculative interpretation, They used two methods, the rank preserving structural failure time and the inverse probability of censoring weighting. It's very statistical, very interesting statistical methods for sure. That's methods are used to simulate a placebo group survival probability in an open label extension, assuming the group remain on placebo treatment rather than crossing over to active drug. And Steve showed the other curve after using these methods. So finally, this is my last slide. Is it time to treat all? I definitely say, please no. We can say that the increased trial is a good start. Definitely it's a good start. But it is a single drug, only just inhaled treprostinil. We don't have any information on others, or very few, or negative trials. The drug works mainly in IPF, and maybe it improves also the pulmonary fibrosis, because we know that the drug also improves the forced vital capacity. It works in severe PH only, not in less severe patients, and the long-term results are, for me, debatable. And finally, there are some disappointing results with other PH drugs, including sildenafil. So I remind you here the guidelines, in particular the last line, the use of PH medication is not recommended in patients with lung disease and non-severe PH, and non-severe PH means PVR of less than 5 Wood units. So, and it is my last sentence and my last statement, treating all PH patients with PH-ILD is not ready for the prime time. So thank you very much.
Thank you so much. Olivier, you can just join us on the stage. It's very interesting, very debate in heterogeneous disease. So just before opening the panel for any question discussions, I would like to hear the response of our audience. So just raise your hand if you think Steve is the win for the debate. Just raise your hand. 2 hands from Majdi. I'll consider it just 1. So we have like 5. Okay, Olivier? Oh. So thank you so much for this debate. So I'm going to open the floor for any questions and discussions. Yes, go ahead.
Yes, thank you really for very interesting debate. I am a pulmonologist, so always I have been interested in treating the patient with lung disease and pulmonary hypertension. There is a missing point, I can say, if I thought, which is about the inflammatory response. Do we have any certain markers that we can point out now at this stage at the biological level that are associated with the severe form of the disease, of the lung disease, who are deteriorating and having the bad prognosis? Do we have any certain markers now that we can look at? Because I think the answer is to go back to the cell biology. These patients, they behave differently, and we see them in our clinics, and they get worse, they die earlier. So I'm sure that they have some kind of different inflammatory response at the baseline. Do we have any research in this field that can point out into these markers?
Okay, go
ahead. Thank you for that question. You could probably tell from my bias that I believe that all patients who qualify for increase should be treated. I think it's a mistake to wait for a particular biomarker, be it hemodynamic, blood biomarker, echo biomarker, to wait to treat these patients when they have such a poor prognosis. I'll give you one anecdote. It's available in the US. I've used it a lot. probably prescribed it to close to 100 patients at this point outside of the study. But I had one patient we did a right heart cath in. The MPAP was 24 and the PVR was 3.5. Put him in for drug. The insurance kicked it back because the MPAP didn't qualify. It wasn't 25. So he was on oxygen already. I followed him along. He got worse. I repeated the heart cath 9 months later, and his MPAP was 50. These patients can have pretty significant progression over a short period of time. Of course, I got the drug approved for him at that point, but he died a month later. The point being, treat early. And just going back to the slide that Olivia showed of the long-term extension, the group not catching up who were formerly on placebo, I would argue is a case not to wait. Don't wait those 16 weeks. They should have been on treatment right at the time of diagnosis. So I think that even if you have an MPAP of 26, PVR 3.1, they should be treated because the natural history is to progress over time. You look at many different conditions we treat. We treat hypertension, we treat high cholesterol for what might happen not 16 weeks later, but 5, 10, 20 years later. So in patients who have a 3-year survival of 30%, the earlier you find it, the earlier you can put them on treatment, the better.
Okay, so the second one.
Thank you. It was a great presentation by both of you, and it's an excellent review. So the question is for Steve. When we look at the last slide you showed, the algorithm of approaching these patients, we know inhaled treprostinil is not available. I can speak for the Middle East area, it's not available. We end up with sildenafil as potential drug. What would be a trial of sildenafil look like in your experience, and how do you monitor the response to that? The second question is, in patients with severe ILD-PH, PVR more than 5, and I see you put IV treprostinil or IV prostaglandin therapy as an option. Would you put a caveat with that? Because sometimes we see these patients with extremely burned out lung. I don't know what the pathobiology that you're treating with IV treprostinil, IV prostaglandin therapy. Can you elaborate on that also?
Yes, thank you for that. And I think, and this maybe answers both questions, I think each patient is an N of 1 study. So you put them on sildenafil, get a 6-minute walk, see how they're feeling, bring them back a week, 2 later, depending on availability, and see how they do. And they'll tell you, I feel better, I don't feel better, the 6-minute walk is improved, they desaturate more. And then you make a decision, do I continue, do I maybe even go up on the dose? So it's very much case by case. And I would say the same for, parenteral prostanoids, it's case by case. And really those patients, you're treating at that point more like a group 1 PAH patients. And anecdotally, we've had a lot of good results. I'd say even in the CPFE patients who tend to have the highest PA pressures, a lot of times I'll put a patient on an IV prostanoid and send them on their way, not expecting to see them come back, and they keep coming back every 3 months. So anecdotally, I think that it does help those patients with severe disease. But to the point, every patient is an N of 1 study by themselves. I think a mistake not to be made is sometimes there is increased VQ mismatch, and they might need more supplemental oxygen. But the bottom line of what we're trying to do is increase their tissue oxygen delivery. So their cardiac output might be improved to the point that it overcomes any desaturation. And a lot of times, anecdotally, the patient might go from 2 to 4 liters, but they feel better. So you go with what the patient feels.
Yeah, go ahead, Doctor.
It was a scintillating talk from both of you. My question is, as a transplant pulmonologist, to Dr. Steve, you have much more experience. I have a bit concern, like when you have pulmonary hypertension in ILD, it's not a referral criteria, it's a listing criteria. And when you start these medicine, which is available to everyone, there is a possibility you are pushing the boat a little bit too much, because when these patients deteriorate, they are going to land in ICU, and then you will be listing them as super urgent. Then you will take some marginal organs, more chances of going on ECMO intraoperatively, and post-operative primary graft dysfunction. So these drugs are promising, but probably should be used with more caution or with more experience, or if we try these drugs, it should be done in close collaboration with the ILD team and the transplant team.
Yeah, I agree, and it's to the same concept of each patient's N of 1, see how they do, and this is where the art of medicine becomes important. Anecdotally, I will say that I think we've seen a bunch of patients and bridged them to transplant by treating their pulmonary hypertension, and it's been my own anecdotal experience that if you treat their pulmonary hypertension pre-transplant, they go into transplant in better shape and they come out of transplant in better shape.
Thank you.
Okay. Dr. Ali,
So thank you. That was really a nice debate. I think we have that debate clinically a lot, especially on the treatments. But I do want to point out something. I mean, in the area we have a nascent transplant programs, right? It's not that we don't have the immediate availability, and I think avoiding that ultimate progression with earlier treatment, with combination therapies is also very important. I mean, we have started a transplant program in the UAE. Saudi has led this, but again, the numbers are small and the access is not what you would imagine. So I think the role of medical therapy, especially with these newer agents that show efficacy, and also, as you mentioned, individualization of therapy for the more severe patients, I think is something we have to put in clinical context. So.
I agree, and I think coming from a transplant background, you have a lower threshold to adopt things that might help, because once they get transplanted, we use a lot of different modalities where there haven't been any RCTs, where we've extrapolated from the kidney, liver literature, heart literature, and I think anything that can get them to transplant and put them in better shape going into a transplant, we're willing to try.
Yeah, just we have one question from Dr. Nasser, and then we'll go to Dr. Hissam.
First, I would like to thank all the speakers. Being a pulmonologist, you know, we sometimes talk high level on the treatment about pH medication, and we forget the most important standard treatment. It reminds me a study done 12 years back by your colleague, Rupe Naye, where there is a good relationship between pulmonary hypertension and acute exacerbation of COPD. Now, if we talk how to prevent COPD exacerbation, we should introduce all the treatment, triple therapy, inhaled corticosteroid. But we keep talking about very high level of medication, and then we forget the beneath drug, which is standard treatment for those juniors. I believe they should understand that is when we talk about pulmonary hypertension in ILD as well as COPD as an antifibrotic, starting antifibrotic early in a patient with interstitial lung disease, and COPD inhalers, in particular inhaled corticosteroid, is an essential. And I believe preventing pulmonary hypertension is more important when we're, you know, treating the outcome of pulmonary hypertension. That is, I need a comment.
I agree. I think the earlier we can get to it, the better. In fact, when you look at trials in ILD and IPF, I think the prevention of pulmonary hypertension could be an endpoint. And it's not feasible in the context of clinical trials in IPF to cath everyone at the start and at the end, but I think the 6-minute walk test, NT-proBNP, are good surrogates for the prevention of pulmonary hypertension that maybe should be considered as secondary endpoints in some of the ILD, IPF clinical trials. Thank you, and the Delta Ford score, yeah. I was sharing with Luke on the plane that I think the only reason we got it published is because in my letter to the editor, I said, we think that the Ford score has wheels, and we hope it finds a parking spot in your esteemed journal. And I think that's what got us in.
Okay, Hissam.
Thank you. Thank you for the interesting debate and discussions in this session. My question is, do we have a plausible scientific explanation to the first part of the trial, the randomized part of the trial, that can explain I have reservations on the result, but that can explain the results that has been presented?
The results of the INCREASE study.
The improvement in the 6-minute walk, and is there can we explain it in a very scientific way? Why did we see this result in these patients?
I think it goes back to that one concept slide I showed where you got the ILD and you got the pH, and if you can improve the pH, especially with exercise, then the patients are going to do more and do better.
But do we know that we improve the pH in these patients?
We don't know that, but I'd argue, you know, the same in group 1 pH studies. Those patients who walk the most, do we know what their pressures have done? And I think the difficulty especially in ILD-PH, is you can get resting right heart cath data, but that doesn't tell you what they do on exercise.
But the molecule historically has not shown the benefits that we ascribe the plausible scientific explanation to as an alone. The inhaled treprostinil has never been approved alone to treat pulmonary hypertension. Just forget about the ILD part. So that even puts the concept or the scientific explanation at a questionable level of are we really doing this for this outcome, or it's just happened to see it in a clinical trial that has a lot of issues. I still believe the two groups were a little bit off. There's some NSIB in one group more than the other that might have driven the 6-minute walk, this difference. We don't know about the steroid treatment. So what I'm trying to say is that we are seeing outcomes, but do we have good explanation to the outcomes that we are looking at?
Well, I'd go to the NT-proBNP, which was unequivocal. It went up in the placebo group, it went down in the treatment arm. So if you want a scientific argument, I'd say we've improved RV stress, and we know that RV failure is the major cause of mortality and poor outcomes in patients with virtually any form of pulmonary hypertension. But I'll throw a question back to you, and which is a bit provocative. Would you rather have a good scientific explanation for why something might work but doesn't work, or not have a good scientific explanation for something that works clinically? And I'd argue all of us want something that works clinically, and sometimes we just can't explain it. But I think there is good explanation for how inhaled treprostinil worked.
My answer is to look at the evidence in a better way. All of these are sampled population. Repeat the study, show me some other more solid scientific evidence that this can work, because the impact will be giving the drug to a lot of other patients that might or might not benefit. So my answer here, I would rather be certain, if possible, than just trying to be happy with my explanation of the thing.
Let me go back 20 years to PAH, where we had very similar studies of Bosent and sildenafil, tadalafil, where we saw results that were equivalent, and yet we readily accepted them for a disease that has a better prognosis than ILD-PH. So why are we raising the bar at the expense of our patients, asking for other studies which are probably not going to happen?
I think it's in the scientific plausibility. If the things are congruent, if everything is fitting, the theory, the background knowledge, the experience from other areas, I can see this working and fitting. But as a standalone one trial that came out, maybe everybody was surprised with the results, probably including you, that this is something that's working. Did anybody expect that this will work? Probably some few people. But again, now we are at the point that we are trying to interpret an outcome that I don't know how did it happen. To be certain, I would repeat the study. Okay. The extension trial that nicely showed by Olivier, that shows that what happened to the other patients. The idea of starting early, I'm not sure how can that fit into the ILD part, not the same as PAH part. So again, we are assuming a lot of things to reach into that conclusion, and that's probably why we have this kind of debate back and forth.
I think we have to conclude because of the time. Thank you so much. Before we conclude, the take message from this session, there is no one size fits all. I think you have to individualize your patients. We don't have any long-term data for the RCT, specifically for group with group 3. So please, whenever you have a patient with severe pulmonary hypertension, refer it to the BH Center. Thank you so much for this amazing talks. I'm going to conclude at this point of time. We're going to have a break for 20 minutes and coming back at 3:30 sharp. Thank you so much.
Okay, Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. Hope everyone got your coffee. So we'll be having exciting session. First, I have to introduce myself. I'm Hanan Fan from the Military Hospital in Jeddah. I'm also the DIO of the Academic and Training. My colleague and my friend, Dr. Nawal Gubaisi, she is a consultant pulmonologist, PH specialist, and the division head in Military Hospital in Dhahran. And our colleague, Dr. Shaya Shaya, he is a consultant pulmonologist, PH specialist, and he is the program director of internal medicine and pulmonary fellowship in the King Fahd Medical City in Riyadh. So I would like to have this chance to thank Dr. Abdullah and the organizing committee for us to chair this session and to sponsor all the fellows and giving them the opportunity to present in such scientific gathering. And I know that this session is, I believe that this is one of the best way to learn and to share our knowledge in the presence of the expertise. I would like to request from the speakers to be on time, please. So each speaker will have 20 minutes. And then you'll have, by the end of your talk, we'll have 1 or 2 questions. So if you can just make it as much, in 15 minutes we're gonna remind you to finish. So we'll give time for the questions.
Okay, this is Dr. Shaya. Thank you for everybody being here with us since morning, and we have a lot of lectures, topics, amazing speakers, as well as attendees. To the end of the day, we have a lot of people sitting here and waiting to the last session of the day. So we'll start the first case, Dr. Muhammad Al-Noor. He's a fellow in King Faisal Specialist Hospital and Research Center in Riyadh. He's gonna talk about aggressive pulmonary arterial hypertension case, the whole spectrum, the whole treatment spectrum. So Dr. Muhammad, go ahead.
Assalamu alaikum and good afternoon to everyone. It's really my pleasure to be presenting this case. First of all, thank you, Dr. Shaya, for the kind introduction. It's really going to be a pleasure for me to, I would say, present this case, but really it's a story, is what I felt. I'm going to be sharing a story of a young female patient who really in the past few months, or in very relatively few months' time, her life turned upside down. For us, her story is really an inspiring one, and what we aim to show within her story is the pulmonary hypertension and how it can present very progressively, how it can have a wide spectrum, and how the course can be very devastating and debilitating for patients. So without further ado, I'll start, just for the sake of time. So our story starts here with this young female patient. She's fairly young, very young actually, 22 years old. She first started noticing symptoms in the form of dyspnea and exertion and some dizziness for the past 2 years prior to her initial presentation. Now, it's important to note that she noticed these symptoms while she was pregnant. She thought that these were normal symptoms. She continued with her pregnancy until the final term date. Her symptoms did, however, progress up until even the 3rd trimester, where her symptoms would progress even more in terms of shortness of breath and in terms of dizziness, to the point that she was around WHO functional class of 3. Now, it's important to note that she did have a full-term delivery with no perioperative complications at the time. She gave birth to a very healthy baby girl. However, she noticed her symptoms progressed even after delivery. Now she started to develop hemoptysis. Initially it was scant, but it continued to progress over the past year or so, give or take. Her symptoms in terms of shortness of breath progressed even more, to the point where even simple daily activities like breastfeeding were very difficult for her, just for the simple fact that she couldn't even just carry her baby to begin with because of the shortness of breath. So, Just a quick review. She had a negative surgical history. Family history was negative for pulmonary hypertension or autoimmune disease. Social history, she was married and living in Medina. And as I mentioned, she has a healthy baby girl with around 1 year and 3 months old. She has no known allergies, and she's not on any medication. So she was electively admitted to the floor, and these were her vitals when she initially presented. So as you can see, she was afebrile, her heart rate was pretty normal. She was very stable, to be honest. Her saturation was 95% on room air. General examination, she was conscious, alert-oriented. She didn't look in distress. Chest was clear. She didn't have any added sounds. She had mainly lower limb edema, which was the significant finding at the time. Otherwise, nothing else. And these were her initial labs. These were the first labs that she did in hospital. As you can see, she had just some slight leukocytosis. She was anemic. Other than that, she had a normal kidney function, hepatic profile. What's very noticeable, I think, which you all noticed probably, is the very high proBNP. As you can see, it was around 3,200. She did initial workup for pulmonary hypertension as well, which included hepatitis and HIV serology, which were negative, and schistosoma antibody, which was negative as well. Now, continuing with the lab, she also had an autoimmune and ANCA workup as well, which all came back negative. Okay. So just a couple of slides on the echo, so you can see. I think you can all appreciate the RV and RA, how significantly large they are. And there's a small rim of pericardial effusion, as you can notice as well. I'm just going to put another slide just to further illustrate these findings. Okay, so this was the echo report, as you can see. So she had the severely dilated RV with moderate dysfunction. She had the severe TR, and her RVSP was calculated to be around 90 to 95. And as you can see, there was a small rim of pericardial effusion in the echo as well. Okay, so it's chest X-ray. I'm sure you can all notice the enlarged cardiac silhouette. Okay, just quickly, I'm going through the investigation. This was her CT chest. This is the lung parenchymal window. I think you can all appreciate now the enlarged pulmonary trunk and also some small scattered centrilobular ground glass opacities in the image as well. Moving on to the mediastinal window, looking for evidence of CTIF and also looking for lymphadenopathies, which was completely negative in the CT report and in the CT image as well. So just for the sake of time, I'm just going to not go through all of it. So mainly very enlarged pulmonary trunk, as you can see. This was the report. It was negative for PE, enlarged right atrium and pulmonary trunk. She had some centrilobular scattered ground glass opacities. We put one and one together. With the leukocytosis, we thought she might be having some sort of infection, pneumonia, basically. She did a VQ scan, and it was negative for CTIF or PE. Ultrasound liver was negative also for any evidence of cirrhosis. And this was her PFTs and her 6-minute walk test. As you can see, she had very mild restrictive pattern, probably due to the pneumonia that she was having at the time. In her 6-minute walk, given she's only 22 years old female patient, she only walked 117 meters, which is really nothing. And her heart rate reached almost up to 140, and she had to stop due to shortness of breath. So you can imagine the extent of debilitating disease that she has. And this is her right heart cath. So as you can see, I think it correlates very well with her presentation. You can see her mean PAP or MPAP is 94. Right atrial pressure also is significantly high. It's 14. PVR was 32, wedge of 10. Cardiac output and index were 2.6 and 2 respectively. For those wondering, they were both done by thermodilution. And PO saturation was significantly low. It was only 35%. And vasoreactive testing was negative. Okay. So as Dr. Olivier showed yesterday, the importance of risk stratification, we now know that given that we have the diagnosis, next step is to know how severe the disease is. And I think we can pretty much imagine at this point where she would fall, right? So and she more or less has a lot of high-risk features. And if we want to go through and calculate it, she'll rack up around 2.6. If you round it up to the nearest integer, that's 3 points, so she's definitely high risk. This is just to further support our claim that she's high risk with a reveal score of 14 points. Okay, so now we have a diagnosis, at least initially, and we have also severity. So now we have to see where we go with our treatment plan, right? So given the 2022 ERS guidelines, now that we have a patient, we know she doesn't have any significant comorbidities, and we certified her as high risk. So now we know that the next step is going to be to start triple therapy. That was the plan for the patient. Okay, so just to go through quickly. So the impression was she's a high-risk pulmonary arterial hypertension patient with negative vasoreactive test. It was between idiopathic and heritable because we sent for genetic testing and we're waiting for the results. So the plan was, as I mentioned, to start triple therapy for the patient, including prostacyclin. However, despite extensive discussion with the patient and family, they refused and they advised, or they preferred, I should say, to start on dual therapy and see how that goes first. So after that, we planned to start the patient on macitentan and riosigwat with Lasix as well, given she had lower limb edema as well, and a discharge with a close follow-up. So instead of our usual 3-month follow-up, we gave her a 2-month follow-up just to see how she was doing. And as all patients we have in our center, we give them all the contact numbers they need should they have any concerns that we should address for them, basically. And for her pneumonia, we gave her antibiotics. Okay, so fast forward 2 months forward, I should say. She's been discharged, and now she comes to the clinic. So initially, she reported some improvement in her symptoms. Her NIHA functional class improved. However, before the visit, a couple of days before, she ran out of her medication, and all her symptoms started to recur again. So she started to have shortness of breath. She started to have hemoptysis again, and also signs of volume overload, lower limb edema, and abdominal distension, and whatnot. And at that time, also, the genetic screen did come positive, back positive for BMPR2. So now we know we're dealing with a hereditary pulmonary arterial hypertension, or HPAH. So, second round of discussion, we discussed again with the family and the patient the importance of admitting the patient and starting prostacyclin therapy as soon as possible. So that's what we did. We admitted the patient, we started the patient on her initial regimen, we put her on IV diuresis given the signs of RV failure, volume overload, and we discussed with them the importance of escalation of therapy with parenteral therapy, basically. So she was, during admission, we did CTPE just to rule out she doesn't have any PE with the hemoptysis she's been having, which was negative. 2 days later, the patient finally agreed to start on prostacyclin therapy. She agreed to start on subcutaneous therapy, not IV. So unfortunately, this is where things start to go or turn for the worst. So during that night, the patient had a rapid response team activated because she started to have tachycardia. Her heart rate reached around 245. She was conscious when she was assessed by the on-call team. She was conscious, alert, oriented. However, she had multiple episodes of syncope, and nausea, and vomiting as well. It's important to notice that the nurse mentioned that the patient reported that she was vomiting blood. That was the initial impression from the nurse as well. And she had just been started on treprostinil around 4 to 5 hours before that. Okay. So I'm just going to go skim through this quickly. So no other systemic review was negative. Examination, she was significantly tachycardic, 240. She was desaturating on room air, 88%. And she had signs that she initially presented with of RV failure. Labs were done, and she had a significantly trending up lactate now, which is around 3.3. She had trending up leukocytes, and hemoglobin was starting to go down. She had persistent hypokalemia, 2.9, which was not corrected despite appropriate measures to correct it. And her proBNP had jumped to 5,600. This was the highest proBNP she had had. This was a chest X-ray that she had at the time, as you can see. And the ECG was done, and she developed an SVT, and the diagnosis was an atrial flutter alternating with atrial fibrillation. So cardiology were contacted, the patient was started on amiodarone, continuous repletion of electrolytes, and the patient was transferred during that same night to CCU to start an amiodarone infusion with telemetry monitoring. Again, it just keeps getting worse. This is just the tip of the iceberg, unfortunately, for this patient. So her blood pressure during that same night continues to go down. Her MAP is going down to 50. Her lactate's jumping up to 9. She's having a picture of DIC with thrombocytopenia and coagulopathy. And this was all during just a few hours. Okay. As you can see, she's starting to go into multi-organ failure now as well. Her creatinine is going up, her LFTs are going up, so she's really in a picture of cardiogenic shock and multi-organ failure. And this is just a picture of what's to come. So you can see now that the patient is having blood clots, significant blood clots coming out. And this is an X-ray of what's to come when she developed diffuse bilateral infiltrates. Okay. So it's important to know this is all happening in a few hours. So this is in the early mornings of the subsequent day. The patient was started on 3 different inotropes, milrinone, and she also started on norepinephrine and epinephrine to maintain her blood pressure. Given her picture of coagulopathy and her hemoptysis, she had the picture of DIC. She was given platelet transfusions, tranexamic acid, and during the early hours of the morning, she was started on VA ECMO, given her severe refractory cardiogenic shock. And she was intubated as well. And it was important to notice that the staff mentioned that the ET tube was filled with blood. So as you can imagine, when the bronchoscopy was done, the confirmation was the patient was having severe pulmonary hemorrhage, which was not responding to cold saline or epinephrine local installations. Okay. This echo was done after the patient was started on ECMO, so that's the important caveat. You can see she has elevated RVSP, probably not as high as before, but it's important to note that the patient is now started on ECMO. So, next day, multidisciplinary team meeting was held, and the plan was to list the patient as an urgent priority for transplant. And the patient was switched from sub-Q to IV treprostinil given her critical condition for better gut absorption. Okay, so just quickly a couple of slides on ECMO. We know that has been illustrated in the previous excellent presentations and talks, how despite we're having a lot of progress in pulmonary arterial hypertension, we know that still it's a disease with very high morbidity and mortality. So at times, even despite our medical therapy and our best attempts to treat patients, a lot of them do deteriorate and unfortunately they die. So the progression to RV failure is still very prevalent, and it's with patients who are refractory to medical diseases, medical therapy. So it's very important to have a very outline regarding when to initiate ECMO or extracorporeal life support for these patients. So just to mention, there should always be a multidisciplinary team before any decision for ECMO, which would include obviously a pulmonary hypertension specialist, a thoracic surgeon, and also an intensivist. And it's always better, whenever possible, we know it's not always possible, excuse me, that the outline goals of therapy are outlined from the beginning. So we know the patients are really going to benefit from ECMO or that it's going to be futile. Because we do know in the end that ECMO is really a bridge. It's not really a destination therapy. So what decisions help us decide if this is a destination, if this patient will benefit from ECMO or not? We know that the baseline demographics matter, right? So like someone like this patient who's very young, she doesn't have any comorbidities, would likely benefit from ECMO compared to other older patients with multiple comorbidities. Course of disease matters. So patients who's having acute decompensation, again, like this patient, will benefit from ECMO in comparison to patients who are having a slow progression of their RV failure. And obviously whether a patient is candidate for surgical therapy. So I think this patient probably meets all of these criteria to benefit from ECMO. And it's always important, obviously, to know the contraindications before we go through. So not every patient, just because they have the indications, mean that they don't have any other contraindications. So just to keep in mind, irreversible neurological damage, ongoing bleeding, especially intracranial bleeding, coagulopathy, inaccessible vessels, all of these are contraindications.
1 minute, Dr. Mohammed. 1 minute.
Okay, sure. Time. So I'll just go through this quickly. So patient had interval therapeutic bronchoscopies during the time while she's being prepared for transplant. Clot removal was being done with every interventional bronchoscopy, therapeutic bronchoscopy. She was being gradually weaned off inotropes, and the treprostinil was being gradually increased as tolerated as well, given her blood pressure. This is just another picture to illustrate the clot burden that the patient had. So finally, 12th of September came, the patient had a bilateral lung transplant, and as you can see, this is her hospital course and event. She was finally decannulated from the ECMO, tracheostomy, transferred to the floor, and finally in December, she was discharged. So she had all of this spectrum of disease in only 6 months or so. And this is just the pathology of the explanted lung, as you can see. I think you can all appreciate the very slit-like openings of the blood vessels and dense interluminal blood vessel thickening and fibrosis and really sclerosis of the blood vessels. And this was confirmed in histopathology. Finally, before I exit the stage, I just want to show how the patient has been doing now. So post-transplant, she comes to the clinic, she's sitting 100% on room air, she's finally living her life as a normal functioning member of society without any limitations. Okay, and this is her chest X-ray. So that's enlarged cardiac silhouette, and that significant cardiomegaly is now normal, really. Okay? So finally, this is probably the slide that's really pushed us to make this presentation. As you can see, in 6 months' time, the patient went through everything, from being electively admitted, to discharge, to readmitted, to ECMO, to IV treprostinil, to an MDT discussion, to transplant. And really the point what we're trying to hone in or zoom in on is that thankfully the patient, fortunately she made it out of it, but had she not been in a PH-capable center which has been able to organize these things in really a few hours, not even days, probably she wouldn't have made it. So it's important just to notice that these are the criteria for a center to be referred or to be deemed as a pulmonary hypertension center. As you can see, the core MDT members should always be there, including 2 PH specialists, ECMO, interventional radiology, should also have an extended MDT team depending on the case, and all these processes should be there. So patient care pathways of how to follow up patients and see how they're doing later on, regular MDT meetings, patient empowering programs like social services and clear communication, quality control audits, so they have also a responsibility to themselves to monitor how the quality of their care is, and finally a responsibility to the public with continuous research, training, and education to really help other facilities and give more data on pulmonary arterial hypertension. So with that, I'll conclude my talk.
Thank you, Dr. Mohammed. Thank you so much. Maybe you can stay there for 1 or 2 questions. It's an amazing, interesting case and amazing team, to be honest. So do you have any question? Go ahead, Professor Mehta.
Mohammed, it was a wonderful presentation. I guess we're all left asking, why was she so severe? What did you learn at explant that might explain the course of her disease?
Well, to be honest, I mean, I know that initially, given her, she had a very severe disease, we had other differential. Could she be having PVOD, PCH, something else that might be explaining this disease? But really, after the explanted lung showed, we just learned that basically she has a very severe form of hereditable PAH. And I think the triggering point that probably made her get worse was probably the hypokalemia on top of what she was going through. Probably just tipped her despite obvious correction. So I think that's what I made out of it, to be honest.
Excellent presentation, thank you,
Thank you.
Dr. Allure. I'm wondering about similar questions. At the time of explant, was there any evidence of substantial arteriovenous malformations in this patient? And maybe at the time of diagnosis, was there a SAT run that might suggest right to left shunting?
When we, unfortunately, this is one of the issues we had with explanted lung. It was significantly thrombosed with a lot of artifacts and blood vessels. But there was, as when we discussed with the pathologist, it just looked like very sclerosed, advanced pulmonary arterial hypertension, with no evidence of anything else. I mean, even when she showed us the slides, they were really slit-like openings. I mean, she was, I don't know how she made it up until that point, to be honest.
Thank you, Paul. We've been seeing these cases with severe pulmonary hypertension, hereditary type. I was telling the team yesterday, they visited our center, I told them that we actually, for even idiopathic pulmonary arterial hypertension, all of them now, we do genetic testing because of the interfamily marriages here in the area. So we think the hereditary type is more common than the West societies. In this particular case, she had the genetic test from day number 1 because he behaved to us as a familial type, as well as being severe from the day number 1 when she presented. And this is what we have noticed in our center. We are seeing patients who came late for some reason, and if they are hereditary type for some reason, they behave even worse. So it came to be PMPR2 positive, and there is also some resistance for IV prostanoids. She wanted to have, remember, she had pregnancy 2 years earlier, right?
Yes.
3 years earlier, 2 years earlier. And that pregnancy went fine. We actually asked them many questions because we doubted that, her previous pregnancy was just smooth one.
Yeah.
Obviously, she had this disease for some time. Yeah. But the reason I asked my fellow to present this case is the fact that, devastating presentation can happen in these patients, and a stormy course can happen. And her particular presenting symptom, beside the shortness of breath, was actually hemoptysis. And in fact, she had massive hemoptysis the night when she deteriorated. If you look at the ET tube, It's almost like an ECMO tube, full of blood. We did several bronchoscopies just to clean, because there was also resistance with ventilating her. The last point I want to make here is when we met with our transplant colleague after she's been on 3 pressors, ECMO, and very sick, there was a resistance actually to list her for transplant because she was very sick. And it happened that earlier, 6 months earlier, there was also a bad case and that, it died after transplant, so they don't want to increase the mortality for their center. But young patients, we really should invest in them. So we actually pushed hard to her to be on top of list, and that's what happened. And now she's a normal person, thanks God. Yeah. So 3 messages from this case. Number 1, it can be a devastating disease, can have a stormy course. Sometimes pregnancy can trigger this. Number 2, please invest in your patient thoroughly. And if you don't have the capabilities of doing this, please send this patient to PH centers, because what happened to this patient from the day she presented to the day she was transplanted and now she is a normal person can only happen when you have all the facilities available in a PH center. Thank you.
Thank you, Prof. Laran, and thank you for our colleague for such an interesting case. Now it's my pleasure to introduce Dr. Hani Sabur. He's a consultant cardiologist in Cleveland Clinic in Abu Dhabi. He has American board in internal medicine, cardiology, echocardiography, and nuclear medicine. And we are about to hear another interesting case with the presentation of hemoptysis, which is quite a challenging presentation for us, pulmonologists and experts in pulmonary hypertension. Go ahead, doctors.
Thank you very much, Dr. Noel. Also, thank you to the organizing committee. This is always an outstanding conference, and it's really fantastic to be part of it. So this is a very complicated case. It's a young 15-year-old girl with shortness of breath and recurrent hemoptysis and an abnormal echo. And we start with the differential diagnosis: CTEPH, vasculitis, PCH, PVOD, HHT, a very wide differential in a sick young girl. So I'd like to also thank Dr. Khalid Saleh, my dear friend, and he actually participated with me in taking care of this case. I'm currently not with Cleveland Clinic, actually. So 15-year-old, it's okay, this is a very recent transition. So 15-year-old female, she was actually referred from a secondary care, one of the referring hospitals in Abu Dhabi, with a 1-year history of progressive exertional dyspnea, chest pain, and palpitations associated with recurrent hemoptysis with sputum production. She herself didn't have syncope or recurrent cough or leg swelling, and she has a positive family history of congenital heart disease, which was another red herring here. So she has shortness of breath with exertion, recurrent hemoptysis, and on examination, she doesn't actually have clubbing. She had a loud S2 with a regular rhythm and normal breath sounds, and no obvious skin or mucosal lesions in the mouth or nose. I just want to focus on this important point. So this is her CT of the chest, basically at the time at the outside hospital when she was referred to us. So this is right lower lobe consolidation with ground glass opacification, as you see. And the bronchoscopy done at the outside hospital showed pulmonary hemorrhage, no mucosal or bronchial lesions, and she had Klebsiella in the bronchial wash and was treated with antibiotics. So what would be the recommended initial evaluation? An echo, a VQ scan, a 6-minute walk, vasculitis serology and anti-nuclear antibody serology, or all of the above. So she did actually have a ventilation perfusion scan, and it showed multiple bilateral mismatch ventilation perfusion defects, and there was no uptake in the brain, thyroid, and kidneys. So for those of us who practice congenital heart disease, this is to show that there is no obvious shunt. So this is very confusing. Why would a child have perfusion abnormalities and no prior history that would go with CTEPH? So another red herring. The echo, at the time of admission to our hospital, she had severe iron deficiency anemia. She had an NT-proBNP of 775, normal inflammatory markers, and a negative D-dimer. Now, the echo was quite severe at the time of presentation, and one of the issues is she wears a niqab, and she didn't want any technologist except for a female to do her echo. So this delayed the echo at the outside hospital. They didn't actually do an echo at the other hospital. So D-shaped septum, RV dilated, and elevated right ventricular systolic pressure, 98 millimeters of mercury in a small kid, late positive bubbles in the left side of the heart with Valsalva, which could suggest an extracardiac shunt or a very small PFO. The patient then underwent a dedicated CT cardiac for congenital anomalies and shunts, and there were no congenital anomalies, no shunts, and there were multiple small peripheral pulmonary artery aneurysms. plus scattered ground glass nodules in random distribution with centrilobular distribution, and also an incidentally enhancing liver lesion. So the plot thickens a little bit. So here's the next question, and this was something quite real, going through daily discussions. The VQ scan is abnormal, what is your next step? Well, she has hemoptysis, and so anticoagulation is contraindicated. Now let's go with an IVC filter. Let's do further investigations with cardiac imaging and a cardiac CT angiography, which was the congenital protocol, a bubble echo to look for right to left shunting, go to right heart cath and selective pulmonary angiography, lower extremity Doppler to extrude DVT. So this is sort of the confusional state that we had at time of evaluation. So a dedicated CT pulmonary angiography was done to assess both this possibility of CTEPH and these pulmonary artery aneurysms and AVMs. And I'm sorry, I don't know if this projects well, but these are sort of high resolution images. And you see in the yellow here and in the red here, there are multiple small peripheral PA aneurysms, and there's obviously no pulmonary emboli, webs, or bands, so there's no evidence of the thromboembolic complication. There are dilated main pulmonary arteries, no pruning of the vessels. There's hypertrophy of the bronchial arterioles, which I'll show in another picture, and multiple small peripheral arteriovenous malformations. So clearly a major vascular anomaly. Now, as we're going through the differential diagnosis, there was a lesion on the liver, so a dedicated MRI of the liver and brain with or without contrast to assess for arteriovenous malformations. So there's multiple hypervascular lesions, about 13 millimeters in the liver, as you see here, with the yellow arrows, suggestive of focal nodular hyperplasia, and then multiple areas of shunting in blue arrows in the arterial phase of the MRI. And this was read by actually a dedicated cardiac radiologist we have in the hospital. And no obvious hepatic arteriovenous malformations. The MRI of the brain, which with angiography, again, did not show any vascular lesions. So as we move along, a right heart cath with a conventional selective pulmonary angiography was done. And here you see there's non-homogeneous perfusion, which matches what you saw on the ventilation perfusion scan. There are more small distal pulmonary arteriovenous malformations, and there's no filling defects, webs, or bands. Hypercoagulable profile was negative, the autoimmune profile was negative, and the lower extremity duplex is negative. So I think the initial problem with the VQ scan is no longer a part of her phenotype or differential diagnosis. Now this is her right heart cath, so the wedge pressure of 11, mean pulmonary artery pressure of 68, cardiac index of 2.8, and the PVR of 16 Woods units, no step up on oxygen, and no response to nitric oxide. 6-minute walk test was 365 with a lower saturation of 97%. But on walking, and remember this is a little girl, her heart rate goes up to 143 beats per minute. And you see here the progression of her NT-proBNP, obviously with treatment. So over the course of a short period of time, from November till February of 2022, she improved her 6-minute walk, but you still have significant dyspnea. So the patient was started actually on macitentan 10 milligrams, as well as Riosigua 3 times a day without significant side effects. Slow up titration of selexipag, which was very slow by necessity due to side effects and a headache, and you saw the BNP trend. So what's the differential diagnosis? And remember, at this point, we still don't have genetic testing. It's not covered by the insurance in the UAE, so it has to be requested individually. So is it chronic thromboembolic pulmonary hypertension, hereditary hemorrhagic telangiectasia? Is it vasculitis, idiopathic PH, or pulmonary veno-occlusive disease? So if you look at the two differential diagnoses, and this is again something we took a long time to sort of try to dissect and look at. So for HHT, there's a possibility you have liver findings, which is focal nodular hyperplasia, and intrahepatic shunting is very common in this and very rare in children as an isolated finding, except in patients with HHT. The presence of pulmonary aneurysms, that goes more with that. The presence of perfusion defects on the VQ scan. However, the absence of family history does not rule it out. Cutaneous examination of skin and oral or nasal lesions, as mentioned, was negative. ENT was seen, but GYN was not done for obvious religious reasons. There was, again, history of hemoptysis, but no epistaxis. So there's plus and minus here. Now, what about pulmonary veno-occlusive disease? If you look at the CT chest, there was no interlobular septal thickening or lymphadenopathy. She tolerated vasodilator therapy without edema. Obviously not a candidate for lung biopsy because of very high risk, generally not recommended. And the centrilobular opacification is not diagnostic, especially in alveolar hemorrhage. So we are, again, with this differential diagnosis. So why did we think that HHT, hereditary hemorrhagic telangiectasia, most likely diagnosis? So there are 7 groups, but 2 major phenotypes. The common variant results in a high cardiac output state due to shunting, and in similar cases with PAH is actually due to a rare form of HHT-related gene in the ENG or ACVRL1 mutation that predisposes to precapillary pulmonary hypertension similar to idiopathic PH. However, we finally got the genetic testing done, and she actually has a BMPR2 mutation. So on triple therapy, so now this is escalating her triple therapy with oral triple therapy. Pulmonary wedge pressure of 8, mean pulmonary artery pressure is 59, cardiac index is actually lower, 2.2, and PVR is 14 Woods units, and the SVO2 of 61% mixed venous. So, and you look at her serial 6-minute walks now in September, she walked more, 458 meters, and the O2 sat, which was 98%, much less dyspneic and less tachycardic with exertion. So with the up titration of the selexipag up to 1,600, again, very slow titration due to side effects, and a repeat right heart cath was done, which we saw here. Due to the high pulmonary vascular resistance and partial response to triple oral therapy, she was started on subcu treprostinil with a reverse down titration of selexipag. So going forward, in November of the same year, now you see that her pulmonary artery pressure is 68. It's almost like the very first one. And she's basically almost resistant to treatment with conventional doses of subcu treprostinil. Now, we had a lot of different discussions with the family at this point, and they were, first of all, completely unconvinced about the need for transplantation. The second point that became very apparent is that as we titrated upwards the treprostinil, she would get slightly better, and then the site would have to be changed because this amount of treprostinil, 213 nanograms per kilogram per minute, is a very high flow through a small needle. So it would actually literally pop out of her skin, and the poor girl would have to change the site every 3 to 4 days, not to mention the normal site reaction. And we realized this was resulting in intermittent subcutaneous absorption with a very thin, she's a very small girl, with little subcutaneous fat and low body weight and variable pH response. So actually consulted with Professor Regina, who's here in the room, and we ended up sending the patient for a Linus Pro pump implantation to convert her to long-term IV therapy and further timing for the lung transplant listing. So this was actually a very successful intervention. We were able to get the Linus Pro pump to fill with 40 milligrams of treprostinil every 30 days at a rate of 1.3 mLs per day, and it was much more constant and reliable. And during that time, she improved her echo, her 6-minute walk, and hemodynamics. However, so this is the Linus Pro pump system. If you're not familiar with it, it's actually something that's quite unique. It's a completely closed loop system. So this is the patient's hub. You inject the medicine through the skin into this reservoir, and it slowly delivers through this. There's no electronic parts to this. It just flows through a vacuum system. It's very efficient. And I'm told it can last for up to 40 years, actually. And this is where it delivers into the superior vena cava. So it's completely closed loop. There's no risk of infection. You don't have to do any dressing changes. We do this in the cath lab. It takes about 10 minutes. And this is actually a publication from 2020 that shows its utilization in pediatric patients. So the continued challenge, in spite of clinical improvement, and this is where the family was like, she's doing great, doctor, is 3 things. Recurrent hemoptysis. So as I can count at least 3 different admissions with really serious hemoptysis requiring ICU admission. You can see these are the bronchial arteries and the collaterals, and multiple episodes of embolization. The next problem is because of her age and size matching, she's very small. We have only just started a very successful lung transplantation program in adults, but no pediatric lung transplant. So this was a major issue. And also, in the interim, we applied for the sotatercept under a compassionate use program or an IDE or whatever we could try to get from Acceleron or Merck, and that was unfortunately turned down. So most recently, because of the recurrent hemoptysis, we've been able to prevail on the family to be considered for lung transplant in the USA. Now, another logistical issue comes up, is the Linus Pro pump is not approved in the United States, and the centers we've contacted in the United States were quite uncomfortable dealing with this, and they wanted to switch her either back to IV or sub-Q. So this is another logistical challenge when you're dealing with these kind of sick patients. So with that, I thank you very much, and we'll open to questions.
Thank you, Dr. Hani, for such an interesting case, and thank you for sticking to the time perfectly. I guess such case will stir lots of questions, and yes,
Hani, thank you for the great case. Very interesting. Do we consider the AV malformations as giant plexiform lesions?
So I think that's really the pathophysiology. We were really baffled until the genetic testing came back, right? And either these are plexiform lesions as part of the disease process itself, or they're part of some phenotype which is closer to HHT. I can't really tell you exactly what it is, but it functions in the same adverse way. And in fact, I think it loads the right ventricle in an excessive manner. If you look at this girl's echo, I didn't want to look at all the imaging. You find a right ventricle that basically occupies more than half her chest cavity. So there's clearly that vascular abnormality and the genetic abnormality. And it's been shown that there's an overlap between the BMPR2 gene and HHT phenotypes as well.
Thank you.
And I think I consulted you once. If you remember, I actually showed you a video of this patient.
Thanks so much, Hani. Wondering if there were any other family members affected and if they've presented in a similar way?
Yeah.
Not known?
No. So we did a very detailed family history, and she's the only one affected. And we've actually asked them to go a little bit further than just get a history and go and get some echoes as well, the extended family.
Thank you, Dr. Hani. Really interesting case. So it's always, if you read about the AVMs, and with hyperpulmonary hypertension, it's always a dilemma on treating those patients. So they act like similar to Eisenmenger syndrome. So I'm not really sure what happened to the patient. You said we did multiple recurrent embolization. So with these embolization, the PVR will go high, and the pulmonary artery pressure will go high,
So
it will worsen the picture.
So actually what we saw is these collaterals are enormous, very large collaterals. I mean, if we can go through this, we didn't have time to go through the interventional radiology. You close one branch, and then a month or two later, she's had 3 others. So this is not a finding that's going to cause a change in the vascular resistance, but you have to do something about the bleeding, because in her case, the bleeding was fairly profuse. I mean, it was literally in the ICU for several days, and the hemoptysis wouldn't stop. So this is actually part of, there's some publications to show that this is the approach that you have to do. It's not a bronchial bleed, it's not a parenchymal bleed. These are large vessels that are powered by arterial flow. So the only approach then you have is interventional radiology, and of course, listing for transplant. So we didn't see, so what's very interesting in this case is that she was never hypoxic. So I showed you her multiple 6-minute walks, she was never hypoxic. So I think the right ventricular function, bad as it was still sufficient to generate enough forward cardiac output, and the degree of arteriovenous bypass was not significant enough to cause.
So do you have a repeated right heart cath after the embolizations?
Typically when she would decompensate, so we have about 4 right heart caths on this patient. Typically when we decompensate, the first thing we want to look at is this worsening RV function, yes or no? Is it interruption of therapy, yes or no? And then, of course, is there a local lesion, which we found in a couple of times. So yes, that strategy is always important. You have to make sure that this is not like the previous case who had massive hemoptysis due to RV failure or RV dysfunction. So in all cases, it was not. But she never had a satisfactory response to treatment. And you notice she required a really enormous amount of vasodilator therapy delivered directly into the venous system in order to at least blunt the effect of the RV dysfunction.
I was sure that such case will stir lots of questions, and we can leave the questions till after the session. Dr. Hani will be still around. I guess it's time to move on to our next speaker. Thank you.
Yeah, the next speaker, I'm delighted to present Dr. Abdullah Al-Harbi. He's one of the active fellows in the Western region. He had the Internal Medicine Saudi board, and now Currently, he is a fellow in National Guard, King Abdulaziz Medical City. He's having a very interesting case, so stay tuned.
Assalamu alaikum. Thank you for the nice introduction and thank you for having me. Today I'm presenting case of pulmonary hypertension with incidental lung lesion. Is my voice clear? So I have nothing to disclose. So let's start with the case. She's a 52-year-old lady. So she's a 52-year-old lady from Asir province, not known to have any medical illness, referred to pulmonary hypertension clinic at King Abdulaziz Medical City with a pulmonary hypertension as evident in echo and incidental lung lesion. So upon evaluating the patient, she's complaining of progressive shortness of breath, WHO function class 3 for the last 1 year, denied any other respiratory complaint, and she doesn't have any other cardiac symptoms like palpitations or couple attack or symptoms suggestive of heart failure. There is no stigmata of chronic liver disease or connective tissue disease, no history of lung or hematological disease, no risk factor for HIV or schistosomiasis, no prior history or family history of VTEs, and she underwent ASD repair 25 years ago. Upon systemic review of the patient, she had significant weight loss. She lost around 4 kg over the last 3 months and denied any other constitutional symptoms. No history suggestive of sleep breathing disorder, no history suggestive of high risk environmental exposure or smoking, and she's not taking any medication or using any herbal therapy. Upon examination, she had average body build. She was vitally stable, maintaining oxygen saturation 100% of room air. Chest examination revealed localized wheeze in the right lower zone, and cardiovascular examination was unremarkable normal first and second heart sound without loud B2 or added sound. Neurological and gastrointestinal and musculoskeletal examination was unremarkable, and there was no lower limb edema. The echo she was referred for showed normal left ventricular function, mildly dilated RV with a TAPSE of 15, and showed of T-jet velocity of 2.9 meter per second with RVSP of 37, and bubble study were negative. This is her X-ray. As we see, she has rounded mass in the right lower zone with the evidence of prior sternotomy. So we're dealing with questionable pulmonary hypertension and lung mass. For the pulmonary, investigation sent for the secondary causes of pulmonary hypertension. Her labs were not impressive. It only showed BNP of 60. Schistosomiasis antibody were negative, HIV were negative, all connective tissue workup came negative, CBC, renal profile, liver profile, all within normal. Her PFT showed mild restrictive pattern with normal DLCO. And CT chest done for her and showed lobulated, smoothly marginated mass in the right lower zone with endobronchial extension, and also showed dilated pulmonary trunk, which suggests of pulmonary hypertension, and also she has multiple large mediastinal lymphadenopathy. For this, PET scan done and showed increased avidity in the mass in the right lower zone and increased uptake in the mediastinal and supraclavicular lymphadenopathy. So we're having right lower lobe suspicious mass with bronchial obstruction and endobronchial extension. We have mediastinal and bilateral supraclavicular lymphadenopathy, plus we have findings suggestive of pulmonary hypertension. At that time, VQ scan was not done as technetium was out of stock during COVID pandemic due to supply chain crisis. So she managed to get the right heart cath prior, and her right heart cath showed pre-capillary pulmonary hypertension with positive vasoreactivity. Her mean pulmonary arterial blood pressure dropped from 52 to 34, and her pulmonary vascular resistance dropped from 9 to 5, without change in her cardiac output. Biopsy taken from the supraclavicular lymph node, which showed metastatic adenocarcinoma with a pulmonary primary, so she's stage 3 adenocarcinoma of the lung. For that, referred for medical oncology. So treatment received for vasoreactive pulmonary hypertension, she was started on 9-fidibine and the dose titrated up gradually, and she showed good clinical response within 1 month. For the lung adenocarcinoma, it's found to be EGFR mutation positive and started on EGFR tyrosine kinase inhibitor. So pulmonary hypertension and lung cancer, is there a link? We have multiple pathophysiological processes to link the pulmonary hypertension with malignancy. One related to direct invasion of the cancer to the pulmonary vasculature, other related to side effect of this malignancy treatment, and other related to high clinical condition associated with this malignancy like VTEs, PEs. So when we speak about the direct malignancy involvement of the pulmonary vasculature, we have macrovascular involvement, where the tumor causes tumor macroembolism and usually involve the proximal pulmonary vasculature. And we have the microvascular, where we have the pulmonary tumor microembolism and the pulmonary tumor thrombotic microangiopathy. The pulmonary tumor microangiopathy, it's a sequelae of the pulmonary tumor microembolism. So initially the tumor cells obstruct the small pulmonary vasculature. With time, when we start to have intimal proliferation, we call it pulmonary tumor thromboembolic microangiopathy. The proposed mechanism for the pulmonary tumor thrombotic microangiopathy that when the tumor needs cause endothelial injury, it will cause a platelet aggregation, and this will release tissue factor and the platelet-driven growth factor and VGF factor and osteopoietin. It's all in turn will cause macrophages activation, and it will cause fibrointimal proliferation, which it will lead to vascular occlusion and development of pulmonary hypertension. And all the previously mentioned finding, it will shows perfusion defect in the VQ study. So are we missing something in this patient? So VQ scan done on follow-up and showed multiple perfusion defect in the right upper lobe, right lower lobe, and the left lower lobe. So the perfusion defect in the left lower lobe, right lower lobe, it's correlated with the site of malignancy. However, it was repeated after treatment and showed persistent perfusion defect in the lateral and posterior basal segment. If we see here, we can see narrowing on the caliber of the pulmonary vasculature. It's related to the mass effect. As per our radiologist, previously it was this pulmonary vascular, it was completely encased by the mass effect. It will be shown in another image. Also, it showed filling defect on the posterior segment of the right upper lobe and showed filling defect on the posterior and lateral basal segment. So she was started on anticoagulation with NOAC. Repeated VQ study showed persistent perfusion defect. So are we dealing with CTIF, seated, or tumoral pH? So due to the multiple distribution of the perfusion defect, it goes more with chronic thromboembolic disease. So are we dealing with vasoreactive pulmonary hypertension or CTIF with positive vasoreactivity? In the ARS guidelines, it's not recommended to look for vasoreactivity in pulmonary hypertension other than idiopathic, heritable, or drug-induced, probably due to safety concern and the ambiguous role of calcium channel blocker in this group of patients. However, the positive vasoreactivity reported in CTIF in multiple studies with a frequency equivalent to the patient with PAH. And one paper suggested that the survival of patient with CTIF with positive acute vasoreactivity testing may be longer and compared with patient with negative acute vasoreactivity testing. However, it was not statistically significant. So for patient with CTIF with positive vasoreactivity, is there a rule for calcium channel blocker? Especially in some of them, they continue to have pulmonary hypertension after getting surgical option. So like in our patient, in case she progressed, should we start riociguat or start other PAH medication like a PDA5 inhibitor? So back to our case, On follow-up, she's currently on nifedipine extended release 150. She's managed to be in low-risk group, and repeated heart cath showed improvement in her hemodynamic, and her pulmonary arterial pressure was 26 and BVR of 2. And for her malignancy, she was continued in the EGFR tyrosine kinase inhibitor. She is she showed good regression, and currently she is in progression-free survival and regular surveillance by her oncologist. And this is her CT on follow-up. As you see, there is regression in the tumor size. And here the mass where it was completely encasing the pulmonary vasculature, and now it's not encasing, but still showing persistent perfusion defect or filling defect. So pulmonary hypertension is a heterogeneous disease with different pathophysiological processes involved in the disease development. Patients frequently have many cofactors contributing to the course of their disease. It's critical to identify specific disease process involved in the patient care. As a result, it will influence further management of the patient. And that's it. Thank you.
Thank you, Dr. Abdullah, for sticking to the time, and interesting case, very complex, with adenocarcinoma, PH, CTEF, vasoreactivity. So any questions? We'll take one or two. Please go
Thank you very much for this nice journey with the patient. But I was concerned about something. You had the decision to do vasoreactivity test. So you thought from the beginning that this patient is a group 1 PH, although we have significant tumor in the lung, suspecting that it's at least group 4 or maybe group 3. This is the routine that you are doing in all cases with pulmonary hypertension, to do vasoreactivity test, whatever the cause. This is the first one. The second thing, after this, you did a follow-up right heart cath to see what happened to the patient after the treatment, the calcium channel blocker treatment, or no?
So yes, it's always for all pulmonary hypertension patients, we should do the VQ study to make sure that she's not a group 4. However, it's in our hospital, routinely we do the vasoreactivity testing, especially if we're suspecting group 1. So in her case, we managed to get the right heart cath before the VQ study. This is why we proceeded with alloprost. But if we are going to stick to the ARS guidelines, probably we're not going to proceed with vasoreactivity. Regarding her response to calcium channel blocker, yes, repeated heart cath repeated 1 year later, and she showed persistent improvement in hemodynamic and preserved vasoreactivity.
Thank you so much, Abdullah, for this, excellent presentation. And the purpose for presenting this presentation in a patient with a cancer is just to identify the many factors that you might came across for such difficult patients, and just to answer the previous questions. For the lung cancer, is not contraindicated to do a vasoreactivity test. If you have like a limited tumors, you might do the vasoreactivity test in a patient, especially with idiopathic pulmonary arterial hypertension, like what happened in this patient. Now, the questions here, is it only pulmonary arterial hypertension reactive or some tumor related that for some instance become reactive? If I want to go back for this patient, like doing right heart cath, I will ask for a cytology from the blood. And this is, I think, what I'm going to do for the next step for this patient, just to prove that this patient having tumor or thrombosis. What happened to this patient last week, just to make it more challenging for this patient, the lymph node, mediastinal lymph node, become enlarged. A biopsy was taken and revealed non-necrotizing granuloma. So non-necrotizing granuloma has been reported in patient with adenocarcinoma as a reaction, sarcoid. She denied any skin manifestation that suggests of sarcoidosis, and there is no lung disease that suggests of sarcoidosis. Or Abdullah, he did a good research, and he found that TKI treatment might cause some sarcoid reaction. So you can see the multiple factors that you came across in a patient. And I'm so glad, so happy for such patients who diagnosed with adenocarcinoma, receiving appropriate medication and receiving a good medication for pulmonary arterial hypertension and surviving for almost like now 5 or 6 years.
Thank you so much, Abdullah.
Thank you very much.
Thank you, Doctor. And, it is our pleasure now to introduce our colleague, Dr. Khalid Al-Ubaidallah. He's a consultant pulmonologist in the Prince Sultan Military Medical City in Riyadh. He did his pulmonary hypertension training in Vancouver City, Canada, and he is going to present an interesting case with a weird or awkward or unique presentation for pulmonary hypertension. Go ahead, Dr. Khalid.
Assalamu alaikum. Thank you, Dr. Nawal, for your kind introduction. I would like to thank you all for staying late until the last session of the second day of this wonderful conference. Due to the limitation of the time, I will begin my talk. So, my story is telling a patient who presented with atypical presentation, patient with BH. She presented with atypical presentation and landed in one of the specialty in our hospital. She had, I'm going to tell the story about her hospital course, management, and workup. So this is a 45-year-old lady. She presented to the emergency with history of loss of consciousness for 1 day. At time of presentation, she had vertigo followed by loss of consciousness, notice at the end with abnormal movement, frothiness, and urine incontinence. She had post-ictal sleepiness for 10 minutes, and dysarthria and numbness over both hands. She had a constant vertigo with multiple episodes of nausea and vomiting. In terms of her systematic review, she had a positive history of frequent episodes of palpitation and lightheadedness the week prior to her presentation. She had intermittent chest pain and numbness over the left arm, which lasted for a minute on multiple occasions. She had no headache, changes in the visual or limb weakness, dysphagia. So the emergency physician, he referred the case to our neurology colleague who evaluated her. At time of evaluation, her vital signs showed she was febrile, tachycardic with heart rate of 119, and blood pressure was on the lower side, 92/68, and she was sitting well in room air. She was conscious, oriented, and alert, looks well, not in distress, chest reported to be clear. Cardiovascular examination, apart from tachycardia, GVB was not evaluated, but she had audible first and loud B2 with no murmur and no lower limb edema. Abdomen was benign, and neurology evaluation reported that her NIH stroke scale was +1 for only dysarthria. Pupils were bilaterally reactive. Her eye movements were intact with no nystagmus. She had no focal neurological deficit. Her presentation, her CBC showed normal white blood cells with hemoglobin and platelet, and normal renal function with creatinine of 78. And part of her initial workup that was ordered by the ER physician, she had a ProBNP that was abnormal. After neurology team evaluation, she was admitted under them as a case of seizures versus syncope for workup. She was planned to have multiple brain images, EEG, started on IV levetiracetam, loading along with cardiology referral for her tachycardia. She was also kept on IV fluid as she is going to have contrast for these brain images. Her CT scan showed no acute ischemic infarction nor intracranial bleed. Her CT angio showed normal both carotid and internal carotid artery. And her AEG at the same day of her presentation was normal with no epileptiform discharges. Her chest X-ray, as you can see, it showed enlarged cardiac size, flattening of the left heart border with left lower lung infiltrate or collapse plus blunting of the left costophrenic angle. Her ECG showed fast atrial fibrillation with fast ventricular response, heart rate of 114. As you can see, the QRS in lead 1 was negative, while it was positive in 2, 3, and AVF, which indicate right axis deviation. So cardiology team saw her at the same time. She reported that the palpitation was there for 1 week. She didn't had any syncope. It was associated with atypical chest pain. So there was no shortness of breath, orthopnea, BND, or syncope before. So their assessment was atrial fibrillation, and at that time they planned to start her on anticoagulation, along with rate control medication, beta blocker, metoprolol 25 BID. They requested echo and Holter, and to be evaluated after the result. So in the next day, as you can see, the patient had deterioration in renal function with doubling of her creatinine. She had deranged liver function with high total bilirubin, ALT, and AST. And with the apixaban, she had next day INR of 3.3 and the ABTT of 51. So due to neurology team, due to the worsening of her renal function, they assumed that this could be related to contrast-induced nephropathy, and they increased the rate of her IV fluid after the consultation with the nephrology to keep her in good hydration. The next day, she had an MRI that showed no significant surrounding edema or mass effect. Next day, early morning, RRT was activated for her because of tachycardia and hypotension. At the time, she had a heart rate of 160, blood pressure was low, 77/39, and she was afebrile, tachypneic, and requiring 5 liters of oxygen to maintain her saturation at 98%. Chest examination was unremarkable, abdomen was benign, no beating edema or signs of VTEs, DVT. She had a VBG that showed combined metabolic and respiratory acidosis with hyperkalemia. So the ICU team impression based after they reviewed the labs for the stat lab for her, she had leukocytosis with mainly neutrophils, worsening of her kidney function, inflammatory marker shows a procal of 1.4 and CRP of 33, and worsening of her proBNP from 2,000 to 5,400. So the impression was, is possible shock status, unclear source versus cardiogenic secondary to arrhythmia. She was managed with adenosine 6 milligram for supraventricular tachycardia, received multiple boluses of IV fluid and sodium bicarb, and medical therapy for her hyperkalemia. So she was started initially on broad-spectrum antibiotic, but because the patient was drowsy and there was no clear focus for her infection, the neurology team thought about meningitis, and they modified her antibiotic. She was on metoprolol 25 BID, and after the IV policies, she was kept on NORAD 0.08. So the next day, her GCS was 13/15. She was drowsy. Her blood pressure is maintained without inotropic support, and her oxygen requirement went down to 2 liters. They continue antibiotic, and she was referred to hepatology and cardiology. Apixaban was being kept on hold as one of the differential of her septic shock is meningitis. They are trying to do an LB for her. So because of the high INR, they give the patient vitamin K, and they failed to correct it so they can perform the LB. Hepatology for the deranged liver function, they said it's going to be for workup with possibility of hepatic encephalopathy. And as usual, they work up the hepatology panel along with starting the patient on lactulose. So her echo showed, next day she had an echo that showed huge dilated RV with RA as well as a rim of pericardial effusion. And the Doppler scan showed severe TR. Her TR max velocity was 4 meters per second, and her TAPSE was 11. And the summary of her echo didn't show any significant left-sided disease or valvular heart disease with severely dilated RV and RV dysfunction. Systolic pressure was 85, and she had a small to moderate pericardial effusion. So at that time, she was finally referred to the pulmonary for pulmonary hypertension evaluation. And when we saw her, she had, we took a detailed history from her. She was more awake we find out that she had dyspnea on exertion for almost 18 months. She, in the last month before her presentation, she barely can walk for 10 meters or can do 10 steps of stair, and she reported no lower limb edema. She visited multiple primary care, and at one stage she was only put on bronchodilator. Her past medical history was unremarkable in terms of other risk factors for pulmonary hypertension. And the next day, upon our examination, she had allowed B2 with holosystolic murmur and elevated GVB, but there was no beating edema. So our recommendation is to stop all the IV fluid, start her on Lasix, plus to start the BH blood work, HRCT, VQ scan. She was not fit to do the 6-minute talk test or the BFT at that time. In early morning, the next day, she reported that she had right upper pain, so the neurology on call assessed the patient and arranged for ultrasound upper limb. That was positive for right upper limb DVT. So when we saw her, we recommend that she should be back on heparin infusion, and due to her critical condition, we started her on sildenafil initially because the blood pressure was on the lower side, and to follow the workup. Her CT chest, as you can see, showed right-sided effusion. Parenchyma doesn't look much involved, no ILD, and her mediastinal window showed dilated pulmonary trunk, as well as enlarged right atrial and right ventricle. The VQ scan done in the same day, it was negative for chronic thromboembolic disease. So, as you know, typically beta blocker usually are commonly used for rate control in other cardiovascular conditions, and we typically avoid it in BH patient due to their potential adverse effect on BVR and lung function. So we plan to discontinue the beta blocker and start the patient on amiodarone. She was admitted to ICU and started on inhaled iloprost, and we increased the sildenafil to 50 TID. In terms of the BH workup, it came back unremarkable, and she was kindly clinically improved with normal hemodynamic of vasopressor. At that time, the 2nd of August, she was on sildenafil and iloprost, plus IV Lasix, and amiodarone with broad-spectrum antibiotic. So in addition to that, 5 days later, we added macitentan, and we modified Lasix for her and planned for right heart cath the following week. So I did right heart cath for her, and as you can see, she had a severe precapillary pulmonary hypertension with a mean of 64, wedge pressure of 11, and BVR of 21, with poor prognostic markers. Inhaled nitric oxide at that time was not available, so it was not done. And we didn't go much in the risk stratification, but most of our markers for this patient falls into the high-risk group. And as you know, after the assessment of the three strata model, with high risk, patient should be on parenteral therapy plus oral dual therapy. So she was gradually improved, still in ICU. We applied physiotherapy for her. Sildenafil was switched to riociguat, and she was referred for psychiatry for depression. So she was, early in September, she was discharged home on triple BH therapy. Treprostinil was ordered to be applied for her the next month, and Lasix was being kept on 40 or once a day with OPD follow-up. So the take home of my message is I'm not illustrating on the management of patients with advanced BH. I'm illustrating about the increase of the awareness of BH. As you know, BH is a rare progressive disease, and early diagnosis is really crucial. Time to diagnosis, despite the advancement of the diagnostic and awareness, still the time to diagnosis is approximately 3 years. And by that time, patient will have multiple visits to the GP specialist before she gets the diagnosis. And usually patient, when they present late, their response to therapy is not much good as when they present early. And at the end, maybe seizures was probably managed by a pulmonologist. So this is a quote that I will end by. So when you hear hoof beats, we think always of horses. Maybe it could be something else. So think zebra. Thank you.
Thank you, Dr. Khalid, for an interesting case. Thank you for such an interesting case. I guess the seizure presentation was probably due to the intermittent decreased cardiac output leading to decreased cerebral perfusion. And classically, it happens with exertion in cases of pulmonary hypertension, although there were cases reported with nocturnal seizure because of pulmonary hypertension. So it's an interesting presentation we should be aware of. The floor is open for questions. Yes, Doctora.
Thank you so much. I was wondering, how would the neurology go far and beyond in investigating seizure? Well, it can be diagnosed by simple history taking in such case. This is number one. And number two, you mentioned that echo is the best tool, is the best screening tool to diagnose. How is it? Is it screening or diagnostic? I believe it's a screening tool for PH. Yeah. The diagnostic is right heart cath.
Yeah, exactly.
Thank you.
So in terms for the neurology, yeah, when she was referred to them, they tried to do all the workup in the first 2 days just to make sure there was no underlying neurological disease. And because of that, she had images, the EEG, before getting the echo. Usually the echo in our hospital will be done not in the first day, but maybe 2 or 3. So because of that, when they found out the pulmonary hypertension, she was referred at that time. Yeah, unless if you think about it, you will take a history. If you don't, you will miss it. Exactly.
So no more questions? May, you have a question? Okay, go ahead.
Thank you, Doctor, for your presentation. I have a general question. Actually, it's not just for you, Doctor, but because I can see there is a need for early diagnostic powerful tool. Instead, I'm not a clinician, I'm a scientist, but this is from a scientist perspective. So would you think that the biomarker would be one of the powerful tools that we can use instead of going through this whole cycle? And another one for the transplantation, there is a need for the 3D bioprinting organs. I think this will revolutionize the medicine and regenerative medicine in general. Thank you.
So in terms of screening, screening means that the patient is asymptomatic. So it's been applied into a special group of patients. Those with family history with heritable PH, they might undergo screening, as well those patients with systemic sclerosis who have high probability to develop PH, they will go under a screening, as well as patients who are eligible for liver transplant. For public use, I don't think so. There is a marker or a blood marker for screening.
Okay, I guess we conclude the session.
So thank you everybody for being with us. Thank you for the speakers and for this amazing, fabulous cases. I would like to thank my co-chairs as well, for the audience, for the organizers for today. Since morning we have a lot of discussions, a lot of topics. Things will be continued to the next day as well. We have 3 sessions in the morning. Tomorrow, bismillah, sessions about miscellaneous, one about the SAPH. I think you'll enjoy it, as well as we're going to interview and sit with our colleagues from other communities and the pulmonary hypertension. We will discuss with them about their experience. So I think tomorrow we'll continue another amazing topics and discussions. So be with us tomorrow. Enjoy your night. Thank you so much.